It's functional only, madam. It's functional, but very scanty people are there.
Oh,
Nobody is traveling. Everybody is dropping their vacations and all. Nobody's traveling.
yeah, because we have our program with AOGD, Delhi Society. So I think we have to drop. From Aurangabad, I'll be flying to Delhi. That is what is the plan.
When are you traveling?
Let's say, no, I found out there it's all fine. Only 2 flights have been cancelled. So I think Delhi is okay as of now.
Ma'am, we are live. Can we start, ma'am?
Yes, yes.
Yes, okay, ma'am. So, good evening, respected faculties and delegates present over here. On behalf of Corona Remedies, I, Shubhankar Dharmadhikari, welcome you all for Core Connect live webinar in association with AMOGS Emergency Obstetric Committee and in association with AOGO. Now, I will take this opportunity to introduce our coordinators for this webinar. So, our first coordinator for our this webinar is Dr. Preeti Dubey ma'am. Dr. Preeti Dubey ma'am is a founder secretary SFM Odisha chapter, and she is the first to start the fetal medicine as a fetal medicine as a subject in the state of Odisha. And apart from this, she is a founder secretary of Society of Fetal Medicine Odisha chapter. Now I will introduce our second coordinator. Welcome, Preeti ma'am. And now I will introduce our second coordinator, that is Dr. Madhusmita Hembram ma'am. She is an associate professor at PMP Talcher and she is also a clinical secretary of AOGO 2024-25 and joint secretary of AOGO 25. Now I will request Dr. Madhusmita Hembram ma'am to introduce our today's convener.
Good afternoon. Our convener is first is Professor Bhagyalakshmi Nayak Madam. She is a professor in the Department of Gynecology Oncology, AS PGI's Cuttack, and she has passed chairperson in Oncology Committee in FOXY 2018 to 20. She's current governing member of ICOG. She was in 2021 to 24. She's president of AOGI India and honorable secretary AGOI. And
Yeah, thank you. So, thank you, Madhusmita. Thank you so much. So I think I really have to thank Dr. Sneha for having put together all the stalwarts together and for this very, very special webinar for AOG on emergency obstetrics, which is actually of a subject of interest for every practicing gynecologist. And Sneha is a dear friend and has been the chairperson of the breast committee, and we were working together, and I have really seen her grit of doing things. Really hats off to you, Sneha. And Dr. Sneha is actually contesting for the post of Vice President West Zone. So request all of you to kindly support her. So thank you so much, Sneha, for putting together all your efforts for this program.
Thank you, dear. Thank you so much. A very good evening to all of you. My respect and regards to all the seniors here. I would like to welcome today's chief guest, respected Dr. P.C. Mahambandar sir, Dr. P.K. Shah sir, and of course the guest of honor, our own AMOGS President, Dr. Kiran Kurtakoti, Dr. Gangadhar Sahu sir, and Dr. Tusharkar sir. I welcome all the esteemed faculties, especially Dr. Murlidhar Pai sir, who will be speaking on the WHO label care guide, and Dr. Sheila Mani madam, who will be speaking on her forte, postpartum hemorrhage, which is a nightmare for every obstetrician. So friends, being the chair of this committee, we have always worked hard, not only reducing the maternal mortality and morbidity, but also the perinatal morbidity and mortality. And that's a very reason all of you will agree to me that obstetrics is very unpredictable, and normal labor and normal delivery is a retrospective diagnosis. At any stage, anything can go abnormal, and that's a very reason we have the stalwarts here to talk in front of you on WHO Labor Care Guide and the subjects related. I'll be moderating the panel discussion on legal emergency. I welcome all of you, all the president and secretaries of AOGO and various societies. And I would like to introduce and invite respected Mahapatra sir. So if sir has joined, Bhagya, whether
Sir
sir
will
has
take
joined.
some time. I think we can go ahead with
Okay.
PK
So
sir.
we would like to invite respected Dr. Shah sir for his words of wisdom and of course guidance for all of us. All of you know sir so well, so I will not ask to display the CV, but sir is the past president of Foxy, IAG and so many other organizations, but above all a very gentle, genuine human being, supporting to the genuine people, and lots to learn from you. Sir, over to you for your precious words.
Thank you very much, Sneha, for your kind words. At the outset, let me thank AMOGS office bearers, Dr. Kiran Kurtakoti, Dr. Rajendra Singh Pardesi, Dr. Bipin Pandit, etc., for having me here, and Chairperson of Emergency Obstetrics, Dr. Sneha Buyar, for inviting me to be a part of this webinar. As has already been told by Dr. Bhagya Lakshmi, Dr. Sneha is contesting for the Vice President post of Foxy for the election year 2025, and I wish her all the very best and success for the same. It is nice to share this platform with a very close friend of mine, Dr. P.C. Mahapatra, who introduced the next generation of gynecologists from Odisha to the world of Foxy. Also, it is nice to see Professor Gangadhar Sahu after a long time, Dr. Bhagya Lakshmi, Dr. Tushar, and can you hear me?
Yes, sir.
Okay. And the two speakers, I am sure both of them are fantastic speakers. And all those who have joined today's webinar will be benefited by these two talks and the panel discussion, which is going to be conducted by Dr. Sneha herself. I really appreciate that Sheila Mane, whom I just met last week at Bengaluru, we had a very good talk or discussion on preterm labor and the management. And she's a fantastic speaker. So I'm sure unfortunately, I don't have time to continue with the webinar as I have to catch a flight back to Bombay to go to Patna and then to Noida next day. So I wish all the very best to Sneha for all her academic activities and all those who are contesting for various posts of Foxy for the year 2025. So thanks a lot for making me a part of it and all the best. Thank you so much.
Thank you, sir. Thank you so much. So I think I don't see PC sir as it. Bhagya?
Yes, Dr. Sneha, can we have the formal lamp lighting also before
Yes.
I think so?
Yeah. So
I think.
Shubhankar, can we have the inauguration video?
Yes, ma'am.
Yeah. Sir was in hurry. That's the reason we have to make little change. First.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
Very good.
I think we can request Dr. Preeti to formally introduce Dr. Sneha. Can we have Dr. Sneha's CV, please?
Can I start, madam?
Yes,
It
Preeti.
is my proud privilege to introduce Sneha, madam. Everybody must be knowing her. She is very active in Foxy and she has done lot of work being as a chairperson in the Foxy Breast Committee from 2019 to 2021. She is also the working committee member of GCM ICOG SAFOG member, and she was chairing the medical disorder committee from 2022 to 2024 in AMOGS, and she is the founder president of Vidarbha ISOPAR. So as Vijay Lakshmi madam has already, she has lots of accolades in her curriculum, so we cannot read all those things, but as Bhagyalakshmi madam has just now told that she is contesting for the West Zone Vice President Foxy. So requesting everyone to vote her, because we know that if efficient people will come to the Foxy, Foxy will flourish further. Thank you, madam.
Thank you, my dear. Thank you so much. So, with God's blessings and the respected PK Shah sir's blessings, we go ahead and we are still waiting for PC sir's blessings. I hope sir has joined.
Sir will join in 2 minutes, I was told.
Okay.
So I think in the meantime, can I introduce Dr. Kiran Kutkuti, sir?
Yeah, that.
Can I have a CV formally? Just so welcome, sir, to AOGO, though virtually. So we are at Orissa welcoming AMOGS to Orissa. So sir is the president of AMOGS. Can I have the CV? And I think I have a special relation with Kiran sir, because when I became the AOGN president, I think the first congratulations I got was from Kiran sir. So thank you very much, sir.
Thank you,
Sir
madam.
has been the chairperson of the MTP committee of
Madam,
Foxy.
that's okay. Madam, it's okay. Fine. That's fine.
Yes, sir.
That's fine.
Yes, sir.
Thank you. Thank you. On
Thank you
behalf
so
of
much,
AMOGS,
and request you for a few words
Yes,
of your wisdom, sir.
well, on behalf of AMOGS, a very warm welcome to all of you. My regards to Dr. PC sir, and also my warm regards to Sujata, Professor Gangadhar Sahu sir, Dr. Tushar Kar, and of course my friend Dr. Muralidhar Pai and everyone, Bhagyalakshmi and everyone. So, the third stage, the culmination of the third stage of the labor is probably the culmination of the hard work the obstetrician does in the first 3 trimesters. And usually in about 80% of the cases, it is okay. But in about 20% of the cases, it goes haywire. And to address to this 20% of the cases, we have a lot of guidelines. And one of them is, of course, the labor care guideline that the first speaker will be talking on. And in case we adhere to these guidelines, most likely the maternal morbidity and mortality will come down. In the same vein, I would like to say that for all of you, those who are watching, to apply the gestosis score to all the patients who are pregnant. I mean, probably I think Karnataka has already started implementing the gestosis score. So I would urge all of you to start using the gestosis score in your routine cases. Well, Sneha, what can I say about you? Heartiest congratulations. I don't know how many webinars you have held, but really your zeal and enthusiasm is, just unmatched for us. So thank you so much for spending every day practically 6 o'clock to 8 o'clock for Amoxians, for Foxians. And I'm sure that all your efforts will not go in vain, and you will be fruitfully decorated this year. So thank you so much, Dr. Sneha. And similarly, Dr. Bhagyalakshmi and everyone who is going to contest for whatever post they are going to do. And my regards to Professor Gangadhar Sahu also, and hello to Tushar Kar also. With that, my good wishes to everyone, and thank you so much. Jai Maharashtra, Vande Mataram, and Bharat Mata ki Jai to everyone.
Thank you so much. Thank you so much, sir, for your good words. So I think we are still waiting for PC sir to join. So in the meantime, I think Dr. Sujata Mishra madam is not available for us. So Madhusmita, can you introduce Gangadhar sir?
Yeah, please go ahead.
Hello. Yes. Professor Dr. Gangadhar Sahu is a retired professor from Bhimsar, Burla, Sambalpur, and ex-dean in IMS, Some Hospital, Bhubaneswar, ex-professor VC in SOA deemed University, and she was president of ISOPAR from 2022 to 23, and she is a very disciplined manner, sir, and very passionate
Thank you,
teacher.
thank you, Madhusmita, thank you. So, my namaskar to one and all. So, special thanks to Sneha, who has invited me to be the guest of honor in this evening. So, esteemed chief guests, guests of honor, all the faculty members, chairpersons, speakers, moderators, and panelists. My namaskar once again to all of you. So I express my heartfelt condolences to the victims of Pahalgam. And now I salute all the Indians, the armed forces, and the government who has responded very well. And we are proud of the bravery of our armed forces. So to start with, if I say now India is in labor, that means labor is unpredictable. So similarly, today's symposium, CME, about this unpredictability of labor and how to minimize the complications of the labor. So the topics are aptly chosen, like the WHO guidelines, how to follow in our delivery rooms. And next is about the most unpredictable and horrible nightmare for the gyneco-obstetricians, that is postpartum hemorrhage. That will be dealt with by none other than the master of PPH, that is Sulamane madam. So next is my very one of the disciples, Sneha. She will be conducting as the moderator of the complications of the labor. And hopefully this CME, this webinar will be a successful one, and it will be very much interesting and interactive. Jai Jagannath, greetings from Odisha and blessings from Lord Jagannath to all of you. Thank you very much for inviting me. Sneha, wish you all the best for your future endeavors. I am always with you, as you have already tested from the very beginning. So once again, I request others, everybody, to stand by Sneha and see that she is crowned as the Vice President of West Zone, Pakshi. Thank you very much.
Thank you, sir. Thank you for your blessings.
Thank you.
I think I request Preeti to introduce Dr. Tusharkar sir.
Yes, ma'am.
Go ahead.
We know everybody must be knowing Professor Tushar Kaura sir. At present, he is the professor and unit head of the Department of Obs and Gynae, SCB Medical College, Cuttack. He is awarded with so many accolades. To name few, he is awarded as Adarsh Chikitsa Award in 2007, Mani Manika Award in 2010, Dharnidhar Award in 2010, Best Medical Publication in 2011, Tarini Pratibha Samman in 2015, Best Original Foxy Journal Publication Award 2018, and recently FRCOG degree by RCOG London 2022 and Odisha Leadership Award in 2023. He is the president of AOGO, he is the chairperson of ICOG 2019 to 20, vice president Foxy 2010, and chairperson of the FOXI Oncology Committee from 2004 to 2009. And he is the national corresponding editor of the FOXI Journal from 2004.
Preeti, thank you.
Thank you,
Thank
sir.
you
We
so much.
welcome you, sir.
Yeah. Thank you. Preeti,
Welcome.
thank you.
Sir.
Yeah. Thank you for your nice introduction. At the outset, I must thank Sneha, my close friend. I treat her always as one of my younger sister, but she really deserving in the Foxy. So many times I tell her that you are a deserving candidate for a Foxy office bearer. So whatsoever it may be, now I thank all the members of the AMOGS to select such type of subject today and select us specially to be involved in the very careful subject in obstetrics, which is a bread and butter of all obstetricians, like labor care guideline, postpartum hemorrhage, complications of the labor. If you remember, you see, as a postgraduate teacher, as a professor, teaching the undergraduate MBBS students, postgraduate MS and MD students, GNB students, coming to the BMOC, CMOC, and SUMAN. Everywhere there is a changing trend in the understanding of the labor. You see the WHO labor care guideline 4 centimeter to 5 centimeter, 6 centimeter. So gradually it is increasing like that. So there is a great change in the understanding of the labor. So all of the teaching faculty who are present here and the students, they understand this, but it must be taken, it must be delivered to the grassroots obstetricians, those who will be understanding the recent WHO care guideline, postpartum hemorrhage, how to deal, what are the things, so that we can hammer on the maternal mortality, or we can address the maternal mortality. If you understand the maternal mortality earlier, the hemorrhage was the number one cause in India. But today, if you see, the number one maternal mortality cause is the SDP, hypertensive disorder of the pregnancy. Now we have addressed the hemorrhage, that is either antepartum, intrapartum, or postpartum hemorrhage. So therefore, like that, if we can address the SDP, that is an emergency obstetrics, perhaps the maternal mortality will be coming down. And Kiran has rightly pointed out the gestosis. The invention of the gestosis, especially by the AMOGS. I remember during our chairmanship ICOG time, that score was given to the FOXY for the widely circulating and follow-up in the India context, so that we can address the hypertensive disorder pregnancy by application of the gestosis score, so that we can address the maternal mortality in the right time. I think the speakers are all are very much competent. They are very much practical. Perhaps this subject would be very much helpful to the those who are participants, especially the audience. Thank you very much again, Sneha, and all the best for your endeavor. And my namaskar to PK sir, Ganga sir, PC sir, and all the seniors, and my love and affection to Sujata, Kiran, Bhagya, and also I must be satisfied if our own candidate, Bhagya, she is contesting for a vice president from East Zone Foxy this time, and Sneha from the West Zone. So I must tell correctly and openly that all of you must support her, and they should come in flying colors. Thank you very much, Sneha and Bhagya, and entire the organizing committee. Thank you very much.
Thank you, sir. Thank you so much.
I think Sneha, sir is getting a bit late, so I think let's go ahead with the scientific program. So when sir is free, we will take his words of wisdom.
Okay, no worries, no worries. We can. So I just thank everybody here with the blessings of God Almighty and all the respected seniors. We go ahead with our academic session, and we hand over the session to Dr. Madhusmita and Dr. Preeti Dubey for the proceedings further. Over to you, Dr.
So we will start our first session.
Yeah.
To chair the session, we have Dr. Jyosnamay Panda. Dr. Jyosnamay Panda, madam, who is the head of the KIMS Hospital, Bhubaneswar. She has a special interest in preventive oncology. She has many publications of national and international repute. She is a life member of FOXY, ISOPER, IAG, and ISAR. Over to you, madam. Okay, the next speaker is Dr. Ranjita Ghade, madam, and my colleague Dr. Madhusmita will introduce Dr. Ranjita. Dr. Madhusmita, are you there?
One
Hello, yes,
person
sir,
can
I'm there.
introduce both the chairpersons for one talk, and no problem.
So Ranjita Ghadei madam is the professor in the gynec department at SCB Medical College, Cuttack. She is the fellow of ICOG, ICMCH, and she is the life member of ISOPERF. She had 15 publications in national and international journal, and her special interest is high-risk pregnancy and urogynecology. I welcome both of you, madam, Ranjita madam and the Josnamai madam, to chair the first
Thank
session.
you. Thank you, Priti, for introducing me. Good evening to all. Uh, so, I thank the organizers and especially Dr. Priti and Dr. Madhusmita and Dr. Bhagyo to having me in this webinar. This is a very important webinar where we know that this WHO care, labor care guide has been designed to give respectable and evidence-based treatment to all women in labor. And we know that the women are very much scared of this labor, and how we can prevent such an increase in cesarean section. That is our motto. So that we have designed this labor care guide to give a comprehensive treatment to patients in labor. And our speaker, should we introduce speaker now?
Yes, please go ahead. Sir,
So please provide the. So I introduce Dr. Murlidhar Pai. He is a Dean, Sikkim Manipal Institute of Medical Sciences, Sikkim, Professor of Obstetrics and Gynecology, and he is the founder and current chairman of Karnataka College of Obstetrics and Gynecology Society. He has given many guest lectures and publications and motivating speaker also. He is one. I remember he had come to our institute also as a motivational speaker, and also in our departments he had given a guest lecture on cesarean section. I am privileged and I am honored to introduce him to this interesting and very important webinar.
Thank you, ma'am. Okay, let me share the. Right. Okay, you are seeing this, right?
Yes, sir. Okay.
Okay. So thank you very much, Dr. Sneha, for inviting me to attend the webinar of yours. And I don't know, as the chief guest said, this may be the more than 200 to 300 webinars that you have conducted in last 3-4 years. And I would like to definitely see you as the Vice President of FOXY this year.
Thank you, sir. Thank you so much.
So what I have done is, all of us know about the origin of the partogram. It was basically designed to prevent the obstructed labor. That means to catch the labor which is going wrong, so that we can prevent the rupture uterus and the consequences of that, ultimately maternal mortality. So this labor care guide is not new. It was conceived somewhere in 2018 and it was introduced in 2020, but soon after that, the COVID came. It did not get the proper advertisement or the circulation that it deserved. Now it's been 5 years. Many of us are still practicing the old WHO partogram, which was not bad. It has served us for many years. Then what is the difference? What was the need of this? In between, the Zhang et al. Brought out a paper saying that the active phase of labor actually starts from 6 centimeters. The old WHO partogram said 4 centimeters. Now that was the dilemma, number one. Number two, all ladies do not follow a fixed timeline, which was there in the old partogram. The old partogram said after 4 centimeters, all women should dilate at the rate of 1 centimeter per hour, which means after 4 centimeters, they should deliver within 6 hours, which was little harsh on many women. We know that all women do not follow the same pattern of labor. That's how experts sat together and brought out more realistic labor care guide. But then what happened once the labor care guide was released, many obstetricians found objectionable things. In that, objectionable means in inverted comma, because they were used to the old partogram, which said once the lady achieves active phase of labor, that is 4 centimeters, they all must deliver in 6 hours. But the new labor care guide said once the lady achieves active phase of labor, which was not 4 centimeters but 5 centimeters, they gave a generous 12 hours, almost double the time. This was not digestible by many and it went into controversy. That's why today I have titled my talk as WHO Labor Care Guide, My Verdict. Of course, this doesn't mean that I'm a judge or I'm the expert. I can give verdict on so many things. It has to be viewed as my opinion. Why I chose this uh, title? Because in another society, I spoke in an ONG, that is Tamil Nadu or society. I was given this topic. There was a debate between old labor care, old WHO partogram and new labor care guide, and I was supposed to give the verdict. So I thought this is a better way of presenting this thing because I hope that most of us already know what is labor care guide. So it is my opinion on labor care guide. What is this WHO labor care guide? It's nothing but a tool, same as old partogram. It's a A4 size paper that aims to support good quality, evidence-based, respectful care during labor and childbirth, irrespective of the setting. That means it can be in primary care, secondary care, or tertiary care hospital, or level of health care for a positive childbirth experience. So obviously, it can be called the next generation partograph. What are the guiding principles? The labor and childbirth should be individualized. That's what I was in my introduction telling. All women do not follow the same pattern. They have different pattern, like each one of us is unique in this world. Each labor will be different in different women and in the same woman in different pregnancies. So it has to be individualized. So I've made the font bigger, change the color, change the font pattern also. And woman-centered. It cannot be doctor-centered. So when I put a tick mark like this, my verdict is that I agree with the statement. Second, no intervention should be implemented without a clear medical indication. Nobody can object for this sentence because unnecessary instrumentation, unnecessary cesarean, unnecessary oxytocin should be avoided. I agree with this. Only interventions that serve an immediate purpose and proven to be beneficial should be prompted. Of course, my tick mark goes there. So, in nutshell, the guiding principles are a clear objective that a positive childbirth experience for the woman and newborn and her family, all the three, should be at the forefront of labor and childbirth care at all times. Yes, I agree. So in other words, the principles include emotional support from a companion of choice. It could be husband or a nurse. Effective communication by the staff, pain relief strategies, regular labor monitoring, oral fluids and food intake, mobility in the labor, pre-established referral plan, and continuity of care, finally leading to respectful labor and childbirth care. Yes, I agree. I have already mentioned when to initiate labor care guide. According to the Labor Care Guide 2020, when the woman enters active phase of first stage, it is not 4 centimeters, it is not 6 centimeters, it is 5 centimeters or more, regardless of her parity, primigravida or multigravida, and membrane status, ruptured or unruptured. Now, what is my verdict on this? Is it correct? Is it fair to start at 5 centimeters? Well, I would put it in a different way. When they say start monitoring and entering at 5 centimeters in the partograph or the new labor care guide, it does not mean that we can neglect the latent phase. Even though we know very well that latent phase can vary somewhere from 8 hours to even 48 hours. We have seen women in latent phase sometimes 1 day, even 2 days. So just because LCG, that is labor care guide, says you start monitoring after 5 centimeter, it does not say you neglect. This has to be clarified. You cannot neglect the latent phase. Then what are we supposed to do? You monitor the same parameters, for example, maternal pulse, BP, contractions, fetal heart rate, and the descent, and maybe once in 4 hours, even cervical dilatation closely, even in the latent phase. This is to be understood clearly. Otherwise, you will simply blame that LCG told us not to bother till 5 centimeters, which is a wrong interpretation. We cannot be all or none and trying to defeat the new labor care guide. But act only if there is gross deviation. Just because the labor is not progressing, don't get frustrated. Especially nowadays, doctors are in a hurry, patients are in a hurry. They want to finish off everything. They want to do cesarean section and get out of it. So we should not do that. We must act only if there is gross deviation. So what is the progress? As I mentioned earlier, this is the old partogram where they put an action line and an alert line at the rate of 1 centimeter per hour. This is unrealistic and fast for some women. I agree with that. It is inaccurate to identify women at risk for adverse birth outcomes. I agree with that. So it is not recommended for this purpose by WHO. I agree. Nor for identification of normal labor progression. I agree. Now, this is where I was hinting, duration of active first stage. Let me again remind you, in the old partograph, in the active stage, which started, of course, at 4 centimeters, they gave 1 centimeter 1 hour. So which means another 6 centimeters means 6 hours. They expected the labor should complete in 6 hours. Or the alert line was put at 1 centimeter per hour. This is very, very harsh. As per LCG, they have given generous 12 hours after 5 centimeters and 10 hours for the multigravida. So is it fair? What is my verdict? One should not blindly wait for 12 hours. This is where we go wrong in interpreting the LCG. Yes, LCG has given us a little more relaxed time, in fact, double the time than the previous partograph, but that does not mean we simply blindly wait for 12 hours and then wonder what to do. We have to monitor very closely. We can take action earlier. It has been beautifully given what is the threshold for taking action. I'm going to talk about this a little later, but at present, I would like to say one should not blindly wait for 12 hours to take the decision for active management. What is the active management? ARM plus oxytocin or instrumental delivery or even emergency cesarean section. Do not go only by cervical dilatation. This 12 hours is given for cervical dilatation, not for anything else. If there's a fetal distress before that, irrespective of the cervical dilatation, take her for section. If there's incoordinate uterine contraction, irrespective of the cervical dilatation, take her for cesarean section. If you think that the head is not going down as per the expectation, if it is very high, cervix is hanging loose in spite of being dilated, take her up for cesarean section because there could be a case of CPD. So what I mean to say, this 12 hours, 10 hours, 2 hours, 3 hours, whatever it is given, it is for the cervical dilatation. But let us understand, cervical dilatation is not the only factor in labor. There are so many factors in cervix itself, whether there is edema in the cervix, whether the cervix is well applied to the head or not, whether there is any caput in the head, whether there's any molding, pathological molding in the head. So there are many factors. We should not blindly go by the number of hours is what I want to highlight. Take decisions based on other parameters, which I've already explained. Now, the old partograph did not have anything about the second stage. That is the novelty of new labor care guide, which also talks about second stage, and it gives us a generous 3 hours in primigravida and 2 hours in multigravida. Many eyebrows will be raised to see, can I wait for 3 hours in second stage? In fact, we used to shout at the PGs for waiting for 3 hours and messing up the case. But now WHO says you can wait for 3 hours. But again, what is my opinion? What is my interpretation? What is my comment? What is my verdict? Do not blindly wait for 3 hours and then say, now what to do? So you have to monitor everything. Again, I will repeat, you see where is the head, whether it is high up, even if it is at zero station, whether it is in the transverse direction, whether there is deep transverse arrest, which means cervix is fully dilated, but nothing is moving further. If there's any fetal distress, if there's any pathological molding, if there's any big caput, then it is criminal to wait for 3 hours. You will wait for 3 hours if everything is going on smoothly, but slowly, that's fine. Nothing is wrong with the mother, nothing is wrong with the baby, and it is just taking little more time is what is the meaning of wait for 3 hours. You can wait for 3 hours, but it is not blind waiting. You can't say that WHO said wait for 3 hours, I waited for 3 hours and nothing happening, now what to do? And what are you doing in between? You have to monitor the FHR every 5 minutes. In fact, FHR can be the single important parameter. I would rather believe that rather than the cervix. Of course, everything is important. Uterine contraction, cervical dilatation, descent of the head, the molding of the head, caput on the head. Everything is important, but what is most important for us is the maternal pulse and maternal BP and fetal heart rate. If these things are not going on well, that means something is wrong somewhere and we have missed it. Because all others are very arbitrary findings, but nobody can make a mistake on the fetal heart rate. If you want, you can use even electronic fetal heart rate monitoring. You will not go wrong. So the WHO labor care guide has same sections almost. It looks also like a old WHO partograph. What only thing is you don't see the action line and alert line here. 2 additional sections have been added. That is, one is supportive care, which I welcome, and shared decision making also I believe in and I welcome. So I put 2 tick marks. The other things are automatically ticked because it was already there in the previous labor care guide. So to zoom in to these things, I will go into the details of this. The monitoring to action, it has got a beautiful plan. First assess, record, check, and plan. So I totally agree with this kind of a approach. Now, let us understand what are these columns and rows. Now, if you can see these columns, the first column, the horizontal time axis, it documents the first stage and second stage. What is boxed in the blue is the first stage. As you can see here, they have given 12 hours. This is from 5 centimeters. That is active phase of labor. And green box is second stage As you can see, they have given maximum 3 hours. Now, what is this each column alert, which is in the red box? This is the beauty of labor care guide. In the old partogram, there was only one guidance for us, or referral point was alert line, action line, nothing else. Whereas in the new labor care guide, for every single parameter that we are monitoring, whether it is mother or the baby, they have given us what is the alert for you, what is the red signal for you, red signal, or what is the threshold for you to take revised decision or refer the patient to higher center. So this is the beauty of labor care guide. So I agree with this totally. As you can see, the timeline is 12 hours. You can enter it like this. Patient came at 6:30 in the morning. After 1 hour, it becomes 7:30. This is for us to write. And when she reaches the second stage, you can write 12:45. So here in this particular case, within 6 hours, that's fine. No problem. Now, let us go section by section. First section is the easiest one. Identification marks, name of the patient, parity, labor onset, and whether she's in active stage of labor or not, when the membrane is ruptured, if at all it has ruptured, and if there's any risk factors. This is the simplest part of the labor care guide, right? Okay. Now, this is how they have written. Let us follow this particular patient only. Second section talks about supportive care, which was not there in the old partogram. It is there in the new partogram. What are the parameters here? 4 parameters: companionship, pain relief, oral fluids, and posture. For each of the parameters, they have told what is alert, what is okay. If you write Y, means yes, there was a companion. Could be husband, could be mother, could be nurse, could be a doctor itself. N means no. If it is no, then it is an alert. You have to revise this. Maybe you have to provide one companion. Pain relief. Y means yes, no means N. And N is an alert. Oral fluids. Y means okay, green signal. N means red signal. Posture. Supine posture is a red signal. We always say in labor, patient should be in the left lateral position, or she should be mobile, but not on her back. So this is perfectly fine. I put a green tick mark. The supportive care also includes this kind of, as I said, this is a blown up picture for us. They have already given us the what is the to be alert, and we have to simply mention that. How do you mention that? It is like this. For example, same patient, Mary Janes, she came at, let's say, 6 o'clock, and 6 o'clock there was no companion. You have written N. N means alert, so we have put a red circle. Pain relief, not given, red circle. Oral fluid, Y means good, so no red circle. Now, posture was, she was mobile, so no red circle. But after 1 hour, she is in supine position, so red circle. Somebody came, so no red circle. Pain relief was given, no red circle. Oral fluid was given anyway, so Y, no red circle. This is how you enter. Very, very, very simple. Now, let us move on to the next part of it, baby, section 3. Here, the parameters are fetal heart rate, deceleration. If there's no deceleration, you write N. Now, N does not always means red. In the previous section, N was red, but here L is red. If there's late deceleration, it's bad. As far as meconium fluid is concerned, if it is M, that is meconium staining of the fluid, is bad. Blood staining is also bad. This was already there in the previous labor partogram. Now it is been made more clear and beautiful. The next parameters, what is the fetal position? Anterior is okay, but posterior and transverse is alert. Caput. 0 caput is welcome, but 3+ molding is bad, alert. Rather caput. Molding, again, sutures overlap, 3+ is bad. So how do you enter that? Again, the baby has got the fetal heart rate, more explicitly written, less than 110, more than 160 is bad. Deceleration, late deceleration is bad, meconium, all these things are given. So how do you enter that? You enter it like this. 6 o'clock when the patient came, fetal heart rate was 140, good. 136, also good, because they have checked every maybe half an hour or 15 minutes. Fetal deceleration not there. Amniotic fluid is clear. C is good. Position is posterior, so a red circle comes. Caput is 0, no red circle. Molding is 0, no red circle. Okay. So let's move on to section 4, which is talking about the mother's parameters. Urine, if there is no proteinuria, or if there is trace proteinuria, you write PT, and P1 plus and P2 plus is alert, 3 plus obviously is alert. Acetone, A2 plus is alert, 3 and 4 obviously will be alert. The next parameter is mother's pulse. Less than 60, more than 120 is bad. Systolic BP less than 80, more than 140 is bad. Diastolic more than 90 is bad. Temperature more than 37.5 or less than 35 is bad. Urine P2 plus A2 plus is bad. So very clearly given at each parameter. That was I was telling. You look at this beautiful alert column. Every single parameter, what is expected is given beautifully. So here, how do we interpret that? Same lady, Mary Jane's, 6 o'clock, pulse 88, okay. Systolic BP 120, okay. Diastolic 80, okay. Temperature 36.5, okay. Urine, nothing, okay. After 4 hours, again, everything is normal. Nothing to put a red circle there, okay. So the next, if you see so far whatever explained, all the 4 sections are here. The first identification section is here. Then we have support case section, baby section, and woman section. This is how it looks. Let's move on to the most important or the controversial area of the labor care guide, that is labor progress in terms of cervical dilatation and the descent. As far as the contraction is concerned, no controversy. If the contractions are less than 2, more than 5 in 10 minutes, it is bad. Duration less than 20, more than 60 is bad. There is no controversy, so I give a green tick. But here, this is the most controversial slide of the new labor care guide. When you look at, can I wait for 6 hours in 5 centimeters? You get a shock. Can I wait for 5 hours in 6 centimeters? Can I wait for 3 hours in 7 centimeters? These things will shock you. When you add all of them, of course, the maximum is 12 hours in next 5 centimeters. Same way, in second stage, can I wait for 3 hours? Can I wait for 2 hours? How do I answer this question? My answer is same, which I've already told earlier. No one should blindly wait for 6 hours, 5 hours, 3 hours, 2.5 hours, or 2 hours. We have to monitor. As long as the baby is going down, though little slowly, as long as the fetal heart rate is steady, no meconium, no molding, no caput, no maternal distress, we can wait for up to 6 hours. The word is up to 6 hours, not blindly 6 hours. I hope I have mentioned it many, many times and I have made it myself clear. Do not go only by cervical dilatation. This is again and again and again I'm telling. That is not the only parameters, though that's been highlighted. There are so many parameters to tell that the labor is going on well or not. For example, if you are dealing with, let's say, if you have given trial of labor or VBAC, the scar tenderness may be one of the factors. Maternal pulse may be one of the factors where you have to abandon this, right? So take decisions based on other parameters, that is mainly fetal heart rate and maternal heart rate. As far as descent is concerned, neither the old partograph nor the new partograph has any parameters, so it's fine. Coming to this, how to interpret this, you have to put an X at that area. And if this alert is not there, you have to put P. Second stage, you have to put P. For example, it is like this. Let's say the patient came at 6 o'clock. She was 5 centimeters. So you have put an X there. Then after, let us say 4 hours, you have done a PV again, and she has progressed to 8 hours. Is it good or bad? It is good. That's why green circle. On the contrary, suppose at 12 o'clock also, she is 5 centimeters, which is 6 hours. I put a red circle. This is not all right. Okay. So you have to reassess. Maybe there is a CPD. Maybe cervix is hanging loose. Maybe there is a caput. Maybe there is a molding. Maybe there is a CPD which was missed earlier. Take her up for section at this late. Don't wait any further. I hope I am clear. Similarly, if it is, let's say, 8 centimeters, I'll go back to the previous situation in 4 hours. And let's say in another 7 hours from the beginning, she has already gone to full dilatation tension, which is fair, which is very good. No problem. And she delivers thereafter. Right? So
हाँ
that's
बोल पल्लवी
yeah. Now the sixth section is the simplest of all,
हाँ
which was there in the previous partograph. Medication, whether you have given oxytocin, whether you have given any other drug, IV fluids, you have to simply say yes or no. Right? So this is how you enter it. Very easy. The seventh and the most important, which is a new addition, that is a shared decision. You have to assess and you have to plan. And both of these things should be informed to the patient. Record the overall assessment and any additional findings not previously documented but important for labor monitoring has to be done. You make a plan. Maybe the plan could be continuation of routine monitoring, or it could be more diagnostic tests, or maybe augmentation with ARM and oxytocin, or it could be a forceps delivery, even a cesarean section. Whatever it is, please share with the patient and write it there. That's very important. So it will be like this. So you assess and you plan and you share with the patient and you write there. So to summarize whatever I said, as far as WHO Labor Care Guide, what are the recommendations 2020? I'll divide it into first stage, second stage, third stage. Green means they are definitely recommended. Let me see whether I agree with or not. Auscultation every 15 minutes. I agree. PV at intervals of 4 hours. I agree. Epidural analgesia where available and possible, give. I agree. Paternal opioids for pain relief, I agree, after 5 centimeters. Relaxation and manual techniques for pain relief, I agree. Maternal mobility, definitely. Of course, not in preterm labor and twins. Oral fluids, yes, yes. So total yes for these recommendations. Now, what is not recommended in first stage on admission? Routine clinical pelvimetry. I put a question mark because we believe in Manipal doing a pelvimetry beforehand so that we don't give her worst of both worlds. What do you mean by that? You allow her to labor, have the pain, midway through the labor, realize that she has got CPD, take her for emergency section. Why do that? Instead of that, do a pelvimetry right in the beginning. So I don't agree with this. Routine admission CTG to assess fetal well-being. Again, I put a question mark because we believe in doing a routine admission CTG so that you know before the labor progresses whether the baby was fine or not. Otherwise, you will be blamed that baby deteriorated after you allowed her into labor. So admission test is always good. Perineal pubic hair shaving prior to giving vaginal birth is not recommended. I leave it to the local practices. Enema for reducing the use of labor augmentation, I leave it to the local practice. The purpose of enema is not this. The purpose of enema is to make sure that in second stage there won't be soiling of the area. Routine vaginal cleansing is not recommended by WHO, but I leave it to the local practice. Sometimes if the vagina is full of infection, better to clean it. Intervention for cervical dilatation of less than 1 centimeter per hour in active stage of labor, I agree with this. It's not recommended. What else is not recommended? Continuous CTG is not recommended. I put a question mark because I believe in doing continuous CTG in high-risk patients at least. IV fluids to shorten labor, of course, I agree because we don't give IV fluids to shorten labor. We give IV fluids rather we keep an IV line. We don't give routinely IV fluids unless the patient is not able to take oral fluids, which is not the case. Active management of labor is not recommended, but I think I put a question mark because sometimes if the labor is not progressing well, if there's no CPT, there's nothing wrong in doing an ARM and putting oxytocin there. But of course, you have to monitor the contractions carefully. Routine and early amniotomy and oxytocin, of course, I agree that it should not be a routine one. It should be case to case. Oxytocin for women with epidural analgesia, I agree because oxytocin need not be given just because you have given epidural analgesia. Epidural analgesia only cuts down the pain, but it does not cut down the action of the uterus. Antispasmodic agents, we used to give once upon a time very freely and routinely. If it was epidocin or rotavirin, but it's not recommended anymore, and I definitely agree now. As far as second stage is concerned, what is green signal? Recommended. Auscultation every 5 minutes, agree. Birth position of individual woman's choice, including upright position, agree. Pushing, encouraged and supported to follow their own urge to push, I agree. It is always better to encourage the lady when she gets the urge to push, not in between. Preventing perineal tear, whatever techniques you use is always welcome. What is not recommended is routine or liberal episiotomy. Of course, we don't give routine episiotomy. We give episiotomy whenever we are using instruments or in a primigravida or if there's a very narrow space or a scarred perineum. Application of manual fundal pressure is not recommended. I totally agree with this. This can cause inversion of uterus. This can cause, abruption and so many other problems. What is recommended in third stage? Uterotonics to prevent postpartum hemorrhage. I agree. I'm sure Dr. Sheila Mane also will agree with this. And you can use any one of them. She's going to talk in details. Delayed clamping is definitely in thing. We have to do that. It will prevent intraventricular hemorrhage. Controlled contraction, yes, that's the way to prevent inversion of the uterus. As far as the massage is concerned, WHO does not recommend it as a routine unless you anticipate postpartum hemorrhage. So that I agree. Thank you so much for your patient listening, and I hope I have clarified all the doubts in labor care guide.
Thank you. Thank you so
Hello.
much, sir. Yes,
Hello.
yes, Ranjita madam. Yes, ma'am.
Yes, I'm Ranjita Khade. Good afternoon and best regards to all my seniors, teachers, and colleagues present here. Actually, I have listened to Professor Murlidhar Pai sir's YouTube video on labor care guide. So many times I have listened to it. But this time it is more refined and much more explainable to everyone, to a MBBS student, to a professor, up to a professor level. It is so much clearly explainable. And but one thing I want to clarify from Murlidhar sir, that it is there since 2020. It is already recommended by WHO by 2020, but we are not practicing this. We are only using the simplified WHO patograph till now. So how we can go to use the
If you ask
modified
me,
labor
ma'am,
care guide?
if you ask me, I feel this is more simplified because at each row, you have an alert there. In the old partogram, other than the action line and alert line, there is nothing much there. Whereas here, this is much more explicit, easier to follow because for every parameter, they have given a ready reference, which is the threshold for taking revised action. So I feel this is more simpler. Unfortunately,
Actually,
we are
Yes,
not
sir.
using it. It
Yes,
should be used.
yes, sir. But we are not yet using it.
no, actually,
Still
Ranjita, what happens? Every part,
Thank you so
everything you
much.
see,
Thank
every
you so
point we
much,
are doing it,
everyone.
but we are not maintaining the record documentation. Here in labor care guide, you see, you are doing either giving oral fluid or you giving IV, but you have to document. That is the
Yeah.
thing in the everything you are doing, but you are not documenting. So
Yeah.
that
Can
is
I
the
just
simplest thing.
interrupt? Can I just interrupt the discussion?
Yes, ma'am.
Thank you so much, Muralidhar sir, for your wonderful talk, and we will continue the discussion. But let us welcome respected Dr. P.C. Mahapatra sir, who had just joined. Sir, good evening and welcome to this program, sir, your own program. And we're very happy to have you, and of course, your blessings, sir, always. We're very eager to listen to your precious words, sir. So, over to you, sir, for your precious words. We have been missing you since so long, and after you for joining here.
My sincere apology for joining late in view of the obstetric emergency here in the OT. But you have emotionally blackmailed me, you and Bhagya, so that I'm forced to join here. And when I joined here and listening to the great teacher Muralidhar, I got many new knowledges from Muralidhar. I know that he's a great teacher. I think at the outset, I must congratulate the AMOGS, EMOC and AOGO, office bearers of the AMOGS, office bearers of the AOGO, and the convener and the coordinators and the guest of honor, and my elder brother, the chief guest, Dr. P.K. Shah, and the whole team of legendary speakers and the teachers present over here for this beautiful webinar on obstetric emergency. Thank you, Sneha, for giving me this opportunity to be associated with this particular learned session. And you see, when I went to the scientific session, it has been really beautifully crafted initially for the rational and scientific management of labor by the WHO Labor Care Guide by no other than the legendary teacher, Dr. Muralidhar Pai, who is very close to me since long 3 decades. I think I was just listening to him. He has beautifully narrated and simplified this labor care guide. The problem which the chairperson raised the question that this beautiful, but why after 5 years it was not very much popular amongst the teaching institutes for that. I fully agree with Jyotsna that the documentation is a major lapses amongst us. I think the mindset should be there for the documentation, and it should start at the level of the medical colleges for that.
Yes.
And that's the, why I feel that, yes, it's one of the deficit that labor care guide should be implemented in all labor rooms, provided the postgraduates and the faculty are well equipped with and give some time for documentation. And you are all doing it. The same thing we're doing it, not much for that. Of course, there are some controversial aspects. There are some institutional variation for that also in one institution to other. But the format is all same for that. Thank you, Muralidhar, for giving me an opportunity to be associated with you and listening part of the program for this. The second important is management of PPH in low resource setting. And it is not, and I'm very happy that the PPH Queen of India and the globe is talking on this aspect. Sheila, you are the PPH Queen. Wherever you go, whenever I see you, I remember PPH. I think the PPH, the uterus contracts, effectively when Sheila is the main speaker for that. And I think I will be waiting for this beautiful session on the second session for the low setting, the PPH management. And the last but not the least, the obstetric emergency, the panel. And the moderator is no other than the Sneha Vuyar, and 6 great panelists will be discussing about this obstetric emergencies in very detail. I think I'm very happy. I thank all of you and Sneha and Bhagya for inviting me to this beautiful webinar and get some knowledge on this for that. Because I think I will get more knowledge by being associated with this type of seminar. And with that, I wish all the best for this webinar. And I am sure the viewers will get really an optimum knowledge and a rational and scientific management of labor events for all time to come for that. Thank you very much, all of you, for giving me this opportunity for that.
Thank you, sir. Thank you so much. And I just take this opportunity to humbly, have your blessings and support for my candidature as Foxy Vice President from Western.
Yeah, you deserve it. You deserved it not now, but much ahead for that also. I told you that. And I hope I will pray God for that.
Sir, thank you so much, sir. Thank you so much. Let us continue with the academic session, and over to you, Dr. Madhusmita and the chairperson. Thank you so much. Please
Hello.
continue, Dr. Josna. Yeah.
For the next session, that is management of PPA's low resource settings, I invite two brilliant chairpersons. So first is Dr. Professor Sasmita Swai Madam. She is professor and HOD of Department of OG Medical College, and she is current vice president of AOGO, secretary of IMA Women's Doctors Wing, IGNO teacher, and special interest in safe motherhood, high risk pregnancy, infertility, and geriatric care. Next is our Dr. Sasmita Behuria Madam. She is currently professor in HOD Department of OG PGIMR Bhubaneswar, and she was UBA Foxy Orator in 2012 to 13 and Foxy
ଆଉ କିଛି
2000
କହନା ଯାହା କରୁଛୁ କହ ଡାଲନା କର ଏଇଠି ଡାଲି ଅଛି
2013. Then
ମୁଗ ଡାଲି
joint secretary AOGO
Sasmita, please
2010 to
mute.
11 and 2012 to 13 and clinical secretary AOGO 16, and she is member in AOGO Focus. She is member editor, and she has received best paper in AOGO 2009 and SOPSI 2018. Thank you. And currently also she was in co-PI in WHO Best Clinical Trial Champion Trial Stepman, and currently she's continuing that.
I think over to Sasmita. Sasmita, please take ahead the program.
yes, good evening. So it is really a very good academic session going on, and thank you Dr. Sneha Madam for this nice webinar, and all the best wishes for your coming election. And now the topic of discussion will be none other than Sheila Mane, and she will be speaking on management of PPH in low resource setting. As Purnasar has already told, Sheila Mane is the PPH lady of India. So it is always very nice to listen from her. I think with the wonderful drug of misoprostol and carbetocin, we have somehow been able to manage PPH, and the NASG has also helped a lot. And the skill development of obstetricians has managed, but still we have a long way to go. So how to manage this PPH in low resource setting? So this is everybody should know about this. It's a must know for all. So without any delay, we should start the program, I think. Dr. Sheila?
I think, can we have Madam's CV for a formal introduction? I know she is known to all of us here.
Yes.
Yeah, Bhagya. We'll proceed. No worry.
Yes, we are waiting to listen from you. Yeah.
Sasmita, please, tell a few words about Madam from.
Dr. Sheila Mane is currently she is working as DNB faculty at KCG Hospital, Bengaluru. She is the ICOG Governing Council member, President
Now I am
ISOPA.
chair-elect, and that is enough.
Yeah, the chair
Sasmita, bas.
Yeah.
We will, Bhagyalakshmi, we will proceed.
This is the old CV. Yes, Madam, please go ahead.
Yeah, we'll proceed. And thank you. And I still remember AICUG at Bhubaneswar, where Dr. Sasmita was the coordinator, and she knows that how we brought all these samples of uterus from Bangalore. And it
I'm
was
really
such
thankful.
Attended by 700 people. Yeah. So I still have those memories. And thank you, Dr. Sneha and Dr. Bhagyalakshmi, and for inviting me for this talk. And as everybody knows that still PPH is a problem for us, I'll just proceed. Share. Can you see my slides?
Yes, we can see it. But make it full screen.
Oh, okay. Wait. I think something happened. I'm not able to make it.
Then go to slideshow.
The slideshow only is not seen here now. It has again minimized slideshow. Yeah. Still not able to do it. I'll stop share and again reshare. Okay, I'll reshare.
Can you please help Sheila, ma'am?
Yes, ma'am.
Please help her, and please mute rest of the participants.
Okay, ma'am. Sure, ma'am.
I don't know what is happening. It is coming like this.
Click
It's not.
click on the
Madam, I
from
think
beginning, ma'am. Click on
first,
from
I think
beginning.
Pardon?
Click on
Edit.
from beginning, ma'am.
from beginning.
Oh, really? Where is that?
And that's
On
on
the
the
extreme
end of
left, ma'am.
your slide. Yes, yes.
Yeah, yeah. Fine. Thank you. Yeah.
Full screen, madam.
So, thank you. So, I felt that when we are talking about, about the our countries like India and Asia, the prevention and preparedness is very important, because unless and until we are prepared, we will not be able to handle. So, it approximately the PPH is found in 5% of all birthing women, and as Dr. Sashmita was saying, yes, with the beautiful drugs, we have controlled like mild and moderate easily. But what we are seeing today is the severe postpartum hemorrhage, and the incidence of severe postpartum hemorrhage is on the rise. And it is very important, particularly in low income countries. If we are handling more of severe PPH, we have to be well prepared. And we also have to look at the near miss cases, because for every maternal death due to PPH, there are 10 near miss cases. So improving the clinical skills and knowledge of the risk factors of PPH are instrumental in preventing maternal morbidity and mortality. And all of us, we know the goal, SDG goal by 2030, it should be 70 per 1 lakh live births. I know most of the South states have achieved, but overall still India, it is 93. So there is still a lot to do. Now, these are the common preventable errors. The first most important is under recognition of the blood loss, lack of appropriate attention to clinical signs of hemorrhage and associated hypovolemia, failure to act decisively with life-saving interventions, and failure to restore blood volume in a timely manner. And I really like this slide, because these are the common errors whenever we find that we have landed up in a near miss situation or we have lost the mother. Now, we can't say that there will be no PPH. In fact, with the rising incidence of cesarean section, we know that there is a more PPH because we are doing more cesarean sections. Now, all of us, we know about the definitions, but for clinical purposes, the definitions is with the blood loss that has the potential to produce hemodynamic instability should be considered as PPH, because we have anemic women, we have small made women, as well as in cases of PIH. And if they are small made, and if we look at their blood volume, if you multiply their weight by 100 or even by 90, it just comes to how much? 35 kg, 40 kg comes to only 4 liters. If this woman loses 25% of the blood, she goes into shock because she has already less blood volume. Now, these 4 T's, all of us are aware, very important. Commonest is atony, but we have to see that tissue, trauma, and thrombin is also taken care. And these are the causes which all of us are aware. What are the causes for atony, for trauma, for retained tissue? Again, we know that another addition nowadays is our placenta accreta syndrome, because again, in the increasing in the incidence of cesarean section. And thrombin, again, we see that more number of high-risk patients we are seeing with preeclampsia, HELLP, bleeding disorders, sepsis, and if they are on drugs like aspirin and heparin. Atony, all of us, we know the causes. Okay, so now there are 3 broad areas in which the outcome from PPH is found to be improved. That is prevention, treatment, and rescue. Now, prevention covers the antenatal strategies, active management of third stage of labor, and the treatment for retained placenta. And PPH treatment covers both medical and surgical, and rescue therapies include IV fluids, blood transfusion, coagulation correction, and supportive care such as compression garments. So, under these 3 heading. Now, as we know that if we have used prevention, we will arrest and there will not be a PPH. But if we find that there is a blood loss, the treatment should start immediately. But if you find that the blood loss is so much that is a class 4 hemorrhage, then you have to deal with rescue management. That is, you will have to act very fast because the death zone is not very far. So The blood loss at delivery showing the dead zone at a loss of over 40% of blood volume, and the 3 strategies for intervention. So, and this data was adopted from Hodge. So antenatal risk factor, again, previous history of PPH, previous history of retained placenta, maternal anemia, again contributing a lot. Now, why the anemic patient is more prone for PPH? There are 5 reasons. One, she has a less number of RBCs. The viscosity is increased because the less number of RBCs. Then, so that patient bleeds more. Then what happens is the lamellar flow in the blood vessels is altered. There are no platelets at the periphery. And then fourth is there is more fibrinolytic activity. So because of more fibrinolysis, the clot disintegrates early and she bloats more. And there is an iron deficiency anemia, which makes the myometrium weak. So there are 5 reasons for the anemic woman to bleed. Yes, maternal age more than 35 or even younger age, body mass index more than 35 kg per square meter, grand multis, APH, over distension, pre-existing uterine anomalies. Now, when we are talking about PPH prevention, we have to assess the risk at every stage, even in labor. Induction of labor patient is more prone if all the stages are prolonged, if there is a secondary arrest of labor, especially in multigravidas, use of oxytocin, precipitate labor, operative delivery could be instrumental or even a cesarean section. So, prevention of PPH. So, the patient safety bundle is, what is the safety bundle? Is a set of straightforward evidence-based recommendations for practice and care processes known to give you better outcomes. Now, the consensus bundle on obstetric hemorrhage is organized into 4 action domains: readiness, recognition and prevention, response, and reporting and system learning. So there are 13 key elements within these 4 action domains. Readiness, every unit, Priyanka, sound. Hemorrhage cart with supplies, checklist, and instruction cards for intrauterine balloons and compression stitches. See, because you may have some junior on duty who doesn't know how to put a balloon when there is. So all this should be kept ready when we talk about readiness. Immediate access to hemorrhage medications, okay? PPH box, establish a response team. You may be in a taluka hospital also, but you should have a response team because you should know who to call when help is needed. Also, you should have your blood bank or a blood storage, and every day the person on duty must check what are the blood groups, how many units are available in blood bank. I must share with you, our blood bank officer share this information every day with us. Okay, so when we are on duty and if we get a patient with some blood, suppose AB positive and we don't have a blood, we are alerted. Okay, then other support also you may need somebody for internal iliac artery ligation, and you may have to shift the patient to tertiary care services. Then you have to establish massive and emergency release transfusion protocols. That is, if your patient is in class 3 and class 4, you know she is going to sink, you don't have to wait. Ask them to release O negative blood, or even a group specific uncross match blood can be transfused. So we have done a MOU with our blood bank because night, if there is no blood bank officer, the technician on duty will refuse to give you. So we have a MOU, and I have told them that you will have to release type O negative blood. Unit education and protocols and unit-based drills are again, and with the post drills, debriefs. So that was in readiness, recognition and prevention for every patient. Assessment of hemorrhage risk. We already discussed measurement of cumulative blood loss plays a very important role. I know that the drape is not available everywhere, but under Laksha, what is said is you have a measurable jug. Once the patient has delivered, amniotic fluid is drained before the separation of placenta. Keep this in the bucket with the Kelly's pad, and the collected blood you can assess the blood loss. That is for the vaginal delivery. For cesarean also, you have to look at the canister or the suction, how much amniotic fluid is there, and later on, how many mops. I will come to that. And active management of third stage of labor where everybody is practicing. Now the response. So we should have a unit standard stage-based obstetric hemorrhage plan with checklist and support program for patients, families, and staff, which is equally important. Reporting and system learning. So we should have audit. We have to establish a culture of hurdles for high-risk patients and post-event briefs, multidisciplinary review of serious hemorrhages for system issues. Because if the blood was not available and you had to refer the patient and patient dies on transit, so unless and until you do the audit, even the administrator will not know what are your problems when you are alone working at taluka. Okay, and monitor the outcomes and the process metrics in perinatal quality improvement, because that will help you to improve your system. Now, readiness is for every unit, and it includes 5 areas of focus to be addressed by every facility to prevent delays. That delay is what? In a facility, it is the third delay. And prepare for the optimal management of obstetric hemorrhage cases, and readiness aims at improving intradepartmental coordination. So when I say third delay, suppose if you are in a FRU, you are sitting in a district hospital, or you have a private hospital where you have all the facilities, the people will refer the patients to you. There should not be any delay when the patient is referred to you, because that is the third delay after patient reaches the facility. Now we know the medication cart. We have oxytocin, we have ergometrin, we have misoprostol. Then we also have carboprost. Now we have added tranexamic acid also, because we know the role of tranexamic acid. We don't have to wait for the oxytocin to act. Okay, that also, and even a carbetocin now for active management of third stage of labor. Now you should be also ready with this, because if you have a traumatic postpartum hemorrhage, you should not be searching speculums and sponge holding forceps. So vaginal retractors, long instruments, sponge holders, balloon also should be there, punjocurate, yes, bright task light and procedural instructions, and also cesarean and laparotomy, hysterectomy tray, all the suture material, and one should be having even the handouts there where they know they should learn that how, immediately if they don't know how to do the compression sutures and procedural instructions. So you have to establish a response team, determine who will be the part of core response team, and the primary maternity care provider, nurse, clinicians from anesthesiology, transfusion service, pharmacy, advanced gynecological surgery, critical care medicine, main operating room, interventional radiology may not be available at every place, and additional nursing resources. And you have to use readily available phone or pager numbers or a rapid response or code system in case of an emergency. If your mother is really collapsing, yes, you will have to initiate the code system, whichever you have, or a blue code blue. And establish a massive and emergency release transfusion protocols and rapid dispensing of RBCs, plasma, and platelets in a predefined ratio intended to preclude development of a dilutional coagulopathy that can result if a significant percentage of patient blood volume is replaced with large quantities of crystallite colloid or RBCs. Now, this is required whenever there is a massive blood loss and you will require a massive. Now, the problems faced by a small nursing home, the problems faced, because Sneha has asked me to talk in a low-income countries, and the taluka hospital and district hospital is the scarcity of blood and blood products. Okay, only blood storage facility. Recently, there was a scenario in a taluka hospital where there was no blood in the blood storage facility, so the patient was shifted, and the patient had a mortality after reaching, because it takes 1.5 hours to reach. So now in Karnataka, we have come out with a solution. In that place, if there are private blood banks, the taluka hospital administrator should have a MOU with that blood bank under JSSK scheme. So whenever the blood is required, even one of the postgraduate or somebody from the hospital or patient attender can go with the blood sample and bring the blood from that blood bank. So under JSSK scheme. So we have started doing that in Karnataka now. As volume is replaced, attention must be paid to coagulation parameters, platelet count, and metabolic status. Now, coagulation profile will take 4 hours to come. Do point of care test. Collect the blood in a syringe. If the test tube is not available, keep it vertically and observe it. Now, maximum, it should clot. If it is not clotting by 8 minutes, you know that your patient has hypofibrinogenemia. 11 minutes, you are definite that the fibrinogen is low, and you have to give her fibrinogen or the products which contains more fibrinogen. So we can do that point of care test also. Yes, we have to do all this on admission. Active management of third stage of labor, I don't think I have to talk to everybody. Why? We have to act fast in golden hour, because at per minute, the person will be losing 700 to 800 ml blood, and the uterus can simply pour and lead to death within minutes. And even smaller blood loss matters, which I already told you. So the golden hour starts now. Once you have diagnosed postpartum hemorrhage, I always say that we should have code H. And whatever you are doing is all at once, not one after another. Shout for help, resuscitate, IV fluids, oxygen. Patient is losing RBCs, give 6 to 8 liters oxygen. Otherwise, she will have hypoxia. Do everything to arrest the bleeding. Massage, bimanual compression, aortic compression, whatever you know you can do, you have to do. And communication plays a very important part with the staff, with the patient and the family, and identify the cause of bleeding. You should have all these things. Gray color cannula, particularly when the patient is bleeding, because the flow rate is 180 ml per minute. Green, it is only 80. So there is a difference of 100 ml. And if your patient has already lost more than 1.5 liter, you will have patient going into shock. So all of us, we know about this resuscitation. You have to start 2 large bore IV accesses, IV set, blood set, 3-way should be there. Get more help, oxygen by mask, and infuse crystallite, either NS or RL. And 3 times to volume, but blood should come early, not more than that. Otherwise, there will be hemodilution. And reserve and get immediately 2 units of PRBC. And you continue your oxytocin drill and medications. All of us, we know after AMTSL, again, you can add 20 units to 500 ml of RL. Now, I would like to add here, if we have used carbetocin for active management of third stage of labor, your oxytocin may not act because the receptors are blocked. In that case, use carboprost directly, or even you can use methylargometrin. And misoprostol is a secondary prompt action. Use carboprost. Okay, identify the cause of bleeding, and we know we should have this chart, and all of us, we know that how soon it acts. Okay, and carboprost contraindications, asthma, patient can develop side effects. Argometrin, patient may develop shivering and all. And argometrin, we don't use it so often, but it is still effective. Particularly, it will, the whole uterus, upper as well as the lower segment, will contract, and the bleeding will get controlled. Oxytocin will act only on the upper segment. So coming to medical management, I already told you about tranexamic acid, which should be used, and it is an antifibrinolytic, so the clot will form. And nowadays, we are also talking about factor 7A. Now, the role of factor 7A, I know it's very easy to talk. It is not easily available. But as I was involved during Dr. Jaideep Tang's time, I must tell you that there are certain states like Rajasthan and Bihar where it is available in the labor room. And in cases of severe postpartum hemorrhage, they have a large experience of using, even Rajasthan also, using factor 7A. Okay, but it has to be a severe PPH. Yes, you will have to infuse IV fluids, you will have to give blood products, but it will arrest the bleeding, even irrespective, even if it is DIC, because factor 7A acts directly at 10A level. Your intrinsic and extrinsic pathways will end at 10A only. So if you give that, that will arrest the bleeding. So there is a use which is happening here, and the government hospitals, those who have it available is for hemophilia. Again, you can have a MOU with the hematology department, and in case of an emergency, you can get it. I know at the dose again depends, at least you will need 3 grams, but at least even if you give 1 ampule, 1 gram, and then refer the patient in case of a severe bleeding, you can save the patient. So there are 39 cases reported in India now where they have really used, and most useful in cases of placenta accreta syndrome. Carbetocin, I think all of us were aware about this champion trial, and which is being used now. So, and which I already told you. Now we have to check whether the patient needs blood. We'll have to alert the blood bank. If there is tachycardia, no waiting, you will have to infuse 2 units of PRBC, and further you order for cross match. Hypotension, you will have to activate the massive transfusion protocol. Now, aortic compression. It does not prevent or delay any of the other steps, but you are controlling the blood loss. So circulating blood volume is restricted to the upper body. Blood pressure is kept higher, blood is prevented, and bleeding area in the pelvis, and you have to carry out. If you are doing a cesarean, take a small wet mop and compress the aorta directly, because sometimes there is so much of torrential bleeding that your patient will have hypotension, and you have to have a qualified person at hand, may have to carry out the compression, or sometimes you may have to change the hand, which we did it recently for a case of secondary PPH. Okay, till we shifted the patient to OT because she was continuously bleeding. Okay, and you will have to check the femoral pulse. So I will not go into the detail, but all of you must remember about aortic compression also. Carbetocin, we know that if you give it IM, the effect will last for 2 hours. If you give it IV, it will last for 1 hour. Okay, but it causes rhythmic continuous contraction of the uterus. So it is recommended now, 2018 guideline. Now, for the massive transfusion, still we do not have the national guidelines, and the criteria are varied and include when patient is actively bleeding and any of the following, like if the systolic blood pressure less than 90, pH less than 7.1, she is hypothermic, INR is more than 2, platelet count is less than 50,000 per cubic millimeter. In that case, you have to ask the patient to reissue 6 units of PRBC, 6 units of FFP, 6 units of platelet, and 10 units of cryoprecipitate. I have to tell you now that there is a more shift toward cryoprecipitate now. Why? Because your patient is bleeding, the fibrinogen is less. If you give cryoprecipitate early, the chances of saving the patients are more. You can give FFP because cryo will take time to come, but FFP is 200 ml. And it has only 2.5 gram per liter fibrinogen. Okay, it has all other coagulant factors also. But again, you are diluting by giving more, and that will again reduce the level of fibrinogen. So give 2 or 3 and switch over to cryo, because cryo, one pool 10 units is only 50. Okay, and if you have given that, you are giving almost 15 to 30 milligram per deciliter to the patient, and that will help. Now we also have injection fibrinogen available. We can give that first and then switch over to cryo, because cryo also contains factor 8. So that factor 8 is also important for clotting. So we can give injection fibrinogen and switch over to. Now you will say, why in low income countries we are talking about that? Yes, we have to be prepared. We have to have 0 deaths due to PPH. Again, I must tell you, since I have involved with maternal death review, we have asked all the district hospitals to keep the fibrinogen as a stock, because they do not get cryo on time, they do not get FFP on time, but at least they can give fibrinogen. The 1 ampule will cost you 10,000, but now all the DHOs and RCH officers have procured and they are keeping it ready. Hemorrhage drills, yes, will definitely strengthen and the staff will be more confident if we conduct the hemorrhage drill and the post-drill debriefing, what went right and what went wrong. So recognition and prevention is every patient. Identification of risk helps to improve readiness, allows increased surveillance and early recognition, increases the use of preventive measures, and prepare the team to initiate early aggressive response. And risk assessment should be considered at multiple time points during patient care, antepartum, on admission, delivery, late in labor. Now, vital parameters to be assessed. Again, the rule of 30. Okay. If all the parameters all of us assess, then if the systolic blood pressure falls by 30, increase in the pulse rate by 30, urinary output less than 30 ml per hour, will indicate that your patient has already lost 30%, means grade 3 hemorrhage. And then you have to give massive blood transfusion. Shock index, which is a very, very simple clinical method, that is the pulse rate divided by systolic blood pressure. More than 1, your patient is in hypovolemia. 0.7 to 0.9 is the normal value. You will have to, and suppose when you start treating the patient, you are in a small nursing home, the shock index improves, you know that your patient is doing better and you feel happy and you don't have to refer her. All of us are aware of this, and shock index will be of a help, particularly in class 1 and class 2, because you still feel your patient is stable, but she is hypovolemic. So if you do the shock index, you will know that your patient is in hypovolemia, class 3, class 4, there is no time. You will have to ask for massive blood loss for massive transfusion. So the risk assessment we discuss. Again, on admission, you can divide the risk into medium and high risk. Okay. Medium is again prenatal we discussed. Already there is Acrita, Previa, BMI more, clinically significant bleeding disorders and other medical surgical risks. Admission, prior cesarean, any other surgery, multiple gestation, multigravida, prior hemorrhage, large myoma, large baby, obesity, hematocrit less than 30 is anemic. Medium risk. High risk, placenta previa, low lying, Acrita, platelet less than 70,000, active bleeding, known coagulopathy, or 2 or more risk factors. So you are prepared. Okay. Again, intrapartum, chorioamnionitis, prolonged oxytocic, prolonged second stage, MAXELF is given, high risk, new active bleeding, or 2 or more medium risk factors. Coming to the measurement of cumulative blood loss, a glance and a guess you will miss by 33 to 50%. So direct measurement of blood loss can be accomplished by 2 complementary approaches. Easiest to initiate is to collect the blood, calibrated under buttock drapes for vaginal birth or calibrated canisters for cesarean. Second approach is to weigh the blood soak items and clots and the weight of dry pads in subtracted from the total weight to obtain an estimate of blood loss. So this is the very simple method. We can have it in labor room and train our people that we can use this. They should be there in labor room or OT, and then people can calculate accordingly and we will be able to estimate the blood loss. Active management of third stage of labor. Now these are the WHO recommendations which are aware. Coming to response, again, every unit, emergency management plan, stage-based management plans have been found to facilitate organized and stepwise response to blood loss and maternal warning sign. So you can also have maternal warning signs, okay? MEOD chart, so that the nurses know that they're shifting from green to amber and amber to red. And they ensure that resources are not wasted and each patient receives optimal therapy. Each institution need to adjust the plan to meet its individual capacity. So I already told you about this, the classification of hemorrhage, what you have to do. Okay, stage 0, patient is high risk, you will keep the cross-matched blood lady. Stage 1, you will transfuse 2 PR bases. Okay, with big bore cannulas, it is 500 to 1000. You will get all the lab investigations done. Along with that, all the measures to control the bleeding. Okay, and uterotonics and tranexamic. Stage 2, when there is ongoing blood loss, and you have to draw and do even fibrinogen levels. Okay. Now, recently we have found out it is not very difficult to get the fibrinogen level done. Okay. You can ask your lab people, because we have started telling every district hospital now that there is auto analyzer and they can just do some modifications and get the fibrinogen levels done. Okay. So if trauma, repair that. Now the patient has gone in for refractory, so you may have to use the balloon. Now we use suction cannulas, which is giving us very good result. Selective embolization is only if the patient is hemodynamically stable. Cesarean, you will have to rule out whether there is any other trauma. You can go for compression sutures. Okay. There could be a bleeding from the placental bed. You may have to take the sutures. If not controlled, then go for stepwise uterine artery, uterovarian ligation, and we may, if there is a rupture, you will have to repair. And last resort is hysterectomy. So you will have to transfuse first 2 units, okay? And then you ask for FFP and start transfusing 2 more units of PRBC. And according to the general condition of the patient, you also ask for coagulation products, okay? I told you in stage 3, the patient has lost almost 1/4 or more than that blood. You will have to mobilize your team, your response team, your hematologist, if you're in a medical college, or your transfusion specialist, if you have, or your urologist who can help you for internal iliac artery, if you are not able to do, or if there is a senior who can do, call them, okay? And you will have to go ahead, maybe sometimes with hysterectomy, and start massive transfusion, O negative first. Support program for patients, families, and staff. Women and their families need timely information reassurance, and opportunities to discuss the incident with the maternity care provider. Very important, every day we face the threat from media. They start taking videos. So we have to talk to them and console them. Reporting and system learning, yes, very important. Establish a culture of hurdles and debriefs need to be written, and multidisciplinary reviews of serious hemorrhages. The purpose is to identify system issues or breakdowns that influence the outcome of the event. As I told you, recently we found in one of the medical colleges, massive transfusion required, cryo is not available. We called the blood bank officer. Why? Because they say we have to freeze cryo for -80, which we do not have. I said, why not? Have you brought it to the notice of the administrators? No. So work on that. So we are doing the maternal death review in so much depth that we are trying to point out. Now, it is not that there has to be a death. Even if there is a situation near miss where we have saved the patient, we do the debriefing, we know what are the gaps, and that should be corrected. Okay. And we know that we don't want to take any legal action, but it will help everybody. So the monitor outcomes and the process metrics important for the successful introduction of quality improvement projects. So the overall goal is to reduce the number of obstetric hemorrhage that escalate into major blood loss, resulting in severe maternal morbidity and mortality. So they have to act when it is mild, moderate, and not allow it to become severe. And yes, improving clinical knowledge, that is conducting drills, attending CMEs, attending programs. Okay, so critical care training is also required here, and you can also involve the other people also in that, your anesthetist, your intensivist, and everybody. And the simulation training. Non-technical skills are important in PPH bundle, like communication, teamwork, and leadership. So the patient is in the center. Okay, you need knowledge, experience, and expertise also. The situational awareness is very important in postpartum hemorrhage. Communication skills are important, and understanding of team members. Multidisciplinary team, infrastructure, and then you should see to it that the staff is trained. Yes, I know nowadays in government it is Dakshata, Laksha. We have Manyata now for private. Antenatal and intrapartum assessment we discussed, and home birth, I will not talk about that, but all of us, we know that these are the things which are available. And now the non-pneumatic anti-shock garment, I must tell you, must be available in every obstetric unit. It will really help you to reduce the blood loss, reduce the mortality. So it must be there. I don't think I can go into the details of that, but an ounce of prevention is worth a pound of cure. All of us, we know that, said by Benjamin Franklin. One more thing I want to tell you is about the EMOTIVE trial. Now, we know about the EMOTIVE trial, which was started by WHO. For what purpose it was started? Because the resuscitative measures have started late. So, E is for estimation of blood loss for every patient. M for massage, O for oxytocin, T for tranexamics, IV fluids, and the last E again, explore. Immediately you have done this, golden hour, explore whether there is a trauma. Do everything and go for refractory management. That could be balloon, that could be suction cannula, blood transfusion, your anti-shock garment, still not help, then go for surgery. So thank you very much for patient hearing. I stop the sharing.
Thank you, madam. Thank you, Sila madam. It was a wonderful speech, and regarding the low resource settings like ours also, it is this talk will help, and it has enlightened all of us regarding the management options. And regarding the drugs, I would like to say about carbetocin, because in low resource settings where the freezing temperature requirement for oxytocin is very low, we can use this carbetocin
Yes,
drug.
we are using.
Also, this drug is very close to my heart because I was a part of this champion trial which we had done at SCB Medical College. When I was there, I, along with Sujata madam, we had conducted this trial. And this carbetocin drug that has completed the inferiority trial. That means that is as good as oxytocin in preventing.
Very true.
Yes, that now the superiority trial is going on, and if it goes through, it will supersede the oxytocin and will be the number one drug for prevention of PPH.
Yeah, I think we have to impress Government of India, Ministry of Health. We are in touch with them that please bring it as an emergency drug, and still they have not done it. We are trying to talk to them, you know. We are going to procure in Karnataka now. We have 5 lakhs deliveries per month. Karnataka government is getting 5 lakhs now. We are waiting for it to come. And I know that if carbetocin is used, it will bring down. And Madhya Pradesh, Devas district, they have done the study with UNICEF. Okay, where 20,000 patients were treated and for AMTSL with carbetocin. And with carbetocin, there is not a single mortality in that Devas district when carbetocin was used. That itself is a big example for us. And we know that Madhya Pradesh is second highest maternal mortality now. So the government of India, because still it is not available in public sector. I know it is a wonderful drug. We are using it. We are able to get it through some NGOs. Yes, private, no doubt. But all of us, we know that the requirement for other uterotonics is also less. And the PPH incidence will definitely less. My own experience when I've done the study in cesarean, if you use it intravenously, there is only 50 ml to 100 ml blood loss. Okay. So it is a very effective drug. Tranexamic acid, not to forget. Okay. And correction of anemia before the patient goes in labor will really take us a long way.
Already been procured in our state. In all our government hospitals, this drug is available. And regarding another thing, I would like to highlight regarding the in low resource settings, regarding the surgical management also, our state government has taken the initiative to teach all the peripheral doctors regarding the devascular stepwise devascularization up to the internal iliac ligation.
Very nice.
So,
Very good.
so many surgeons, many obstetricians have now learned it. And I am the professor and head of the department of PGIMR Bhubaneswar, and we are also in our institute, we have carbetocin in plentifully available in our department. And also know also the compression sutures. About the compression sutures, I would like to highlight one thing, that is one compression suture, that is Gunasila, which is very much effective in as much as 100. In my experience, it is almost 100% effective in controlling the atonic PPH if there is no DIC.
Which compression suture?
Gunasila's compression suture.
Is it different from Heyman's or Billing?
Yeah, it is very much different. It is a Gunasila's global suture.
Vertical and transverse?
3 to 4 tire sutures are made all around the uterus.
That is transverse?
Yes.
Circular.
Okay.
Yes, transverse suture.
Okay, we are getting late, I think. So thank you, Dr. Sheila, for your excellent talk. Really, you have enthused the passion to treat PPH in everybody. All the obstetricians joined today, they must be so passionate to treat PPH and prevent the death due to postpartum hemorrhage. And I think I must tell that all of us are concentrating only on atonic PPH, but we should not ignore the traumatic also. Because nowadays there are many patients are coming to us with traumatic PPH also. So that part we should not forget. So thank you for your nice talk. It was really wonderful. Okay, thank you.
Thank you, Sheila madam. Thank you, chairperson. So we will now.
And before I end, I must tell you that my best wishes to my dear friend Sneha.
Yes.
Okay, Sneha? And all of us have to see that we see her in that post this year, definitely. Okay? God bless you. All our prayers with you, Sneha.
Thank you, madam. That is most needed. Thank you so much.
Thank you so much, madam. So we are now moving to our last panel discussion, the most awaiting one. The theme of this panel discussion is on labor emergencies that we are facing in day-to-day life. So we have our moderator, none other than the Sneha Bhuar, who is the mastermind behind this webinar. And we have two experts, Dr. Jayashree Patnaik madam and Dr. Sasmita Bahuria madam. We have already introduced Dr. Sneha Bhuar madam and
Yes. I think go ahead with, you can skip the introductions and go ahead.
So yes, we will start with Jayashree Patnaik madam. I am proud, privileged to introduce Jayashree madam. I think So behind every successful man, there is a woman, and she is none other than Jayashree Madam, who has made BCSM to the global level, and sir is pulling and pushing all the gynecologists of Odisha to every corner of the world. We are really thankful to the couple. And Madam is the
Priti.
and Madam is retired as the Joint Director, Health and Family Welfare, Director of Prachi Institute of Mother and Child Care. She's the President of AOGO and immediate past Chairperson of ISAR Odisha. She is the Chairperson for Prachi Educational Foundation, who keeps on doing numerous educational activities in the entire Odisha and has special interest in the field of ultrasound and infertility. Thank you, Madam. And
Thank you,
then we
Priti,
have
for your nice introduction. Thank you.
Thank you, madam, for joining, and we are very happy to have you as expert.
Thank you. We are already late, so
That is
I will
Priti,
request Dr. Sneha to start early.
Yes.
Let me introduce our panelists. Our first panelist is Dr. G. Prasanna. She is the Professor of King.
I think, Priti, I think we should value madam's request also, and we should go ahead with the, directly with the panel discussion. I just welcome all, both the experts, Madam Jayashree Patnaik and Dr. Sasmita Behuria. And I welcome all the panelists, Dr. G. Prasanna, Dr. Jasmina, Dr. Madhusmita, Dr. Abhishek Khuzur, Dr. Sagarika, and Dr. Vandana Mahapatra. And without much ado, we go ahead with the panel discussion straight away. So friends, all of you have heard about the WHO labor care guide, and how meticulously we are supposed to monitor the labor. And it's not, it's a sentinel event in any woman's life. All of you are, I'm sure you know that it's almost a second birth. Birth is intensely emotional and physical, and it's not as easy as is shown in all the movies. 1, 2, 3 pushes and the baby's out and things are, everything is happy. So the aim of labor is, of course, a healthy baby from a healthy mother, and it should be an emotionally fulfilling experience for the mother. So we start with Dr. Prasanna. We've taken very simple practical cases, and we request you to be very quick and crisp. So Dr. Prasanna,
yes,
we have first case for you, primary gravida, 37 weeks. She comes to you in early labor. Her vitals are normal. Contractions are every 25 seconds, every 4 minutes, and head is floating. Fetal heart is good, 140 per minute. There's sudden drop in fetal heart rate. So what is your diagnosis, and how would you manage this patient?
So in this case, madam, she is a primary gravida who is in early labor with a floating head. This is the important thing which we have to keep in our mind. Ki where there's unengaged head with early labor, the chances of coning of membranes and displacement of the cord into that can be one of the most common cause in this, because she can develop sudden rupture of membranes, and there could be a case of cord prolapse which will lead to the fetal heart rate reduction. The one more, so this is my first diagnosis, madam.
Yeah. So how would you confirm that?
So by first of all, starting from the examination itself, suppose she's a primary gravida where she is in the early phase, you have to assess the pelvis, where the contracted pelvis is there.
Dr. Prasanna, sorry to interrupt you. You're perfect on your diagnosis. It is a case of cord prolapse. I'm just asking you, how do you confirm that she has had cord prolapse for this patient?
Yes, madam. By looking into the perspectum examination, we will see the cord, if the loops are seen in the pervaginum, and also if you feel there is a palpation of the cord prolapse with the pulsations, whether they are present or not. So this is the presence of cord itself in the vagina is a confirmatory diagnosis for prolapse, where it can.
She will give you history of, something, licking from outside, and, she's wetting her clothes. So when you examine, you will find that there are rupture of membranes, and then you can see the cord, and that can be the frank cord prolapse or overt. But sometimes, you have this picture, and when you examine, you don't see any cord. So what is it, and then how do you confirm that?
So a presence of a card is can be of occult variety, where you cannot feel any presence of the card at the level of presentation. That's a compound presentation, where by the side of the head or breech, especially you suspect the same, the presence of cord at the lower uterine segment will be assessed with, especially for malpresentations like breech presentation, transverse lie, and multifetal gestations, polyhydramnios. These are the various conditions you have to have a prediction of cord prolapse, and the labor with the head is one of the most.
We'll come to the prediction later on. So that was wonderful. Coming to the diagnosis now, Dr. Madhusmita, how will you go ahead with the management for this patient now onwards? She's diagnosed with a case of cord prolapse. How do you manage?
Yes, suppose it is now already diagnosed, so first I will call for extra help. I'll call immediately call the anesthetist. That might be need for emergency cesarean section and pediatrician definitely. In simultaneously, I'll keep the patient in left lateral position, and also I'll just try to elevate the head presenting part so that there won't be any compression, and I'll fill the bladder so that there won't be any compression on the cord. Next, then further depends on the what is the how much is the dilated. If it is already in second stage type, already about to be delivered, then we can just accelerate with instrumental delivery. But if it is only 4-6 centimeters, then we have to immediately go for category 1 cesarean section, ready the OT, and like within 30 minutes maximum we have to deliver.
Right. So your aim should be deliver the baby as soon as possible, whatever may be the modality. If you feel that she's going to deliver vaginally at the earliest, maybe by instrumentation or manipulation, yes, you can go ahead with the delivery vaginally. But of course, keeping everything ready for cesarean section. Right. And if you don't have the adequate dilatation, you have to take her for cesarean section, a crash cesarean section. But meanwhile, how should be the position of the mother? You have already said left lateral and head low, but preferably maybe that is the knee chest position. The mother be on forelimbs, I think, and of oxygen supplementation. That is most important. So what are the conditions, Jasmina, in which you feel that there is a possibility of cord presentation or cord prolapse?
Yes, madam. As Prasanna already told, like when there is no engagement is delayed or unengaged presentation is there, like mostly it happens in prematurity or when there is unstable lie is there because of excessive like polyhydramnios condition, and in malpresentation like compound presentation, transverse lie, when the breech is having footling presentation or the breech is in flex position, then in those condition engagement doesn't take place, and also in contracted pelvis. And sometimes we see when there is low-lying placenta with velamentous insertion of cord is there, unknowingly we do ARM, suddenly cord will come out. These are the commonest condition we encounter in our emergencies labor.
Yes, perfect. So how do you prevent this? How can you prevent this? What are the AOGO guidelines for prevention of cord prolapse?
Ma'am, like we have to be more vigilant. In these high-risk patients, we have to be more vigilant. And we have to do an ultrasound, like etiology has to be known, like where is the placenta and what is the presentation or what is the lie of the fetus before inducing a case or before planning for delivery, the mode of delivery.
When should be the ideal time to go for ultrasound in such cases?
Usually at around after 36 weeks,
36 to 30.
primary gravida. In this case, like primary gravida, we know engagement will take place after 37 weeks. So better to know the lie of the patient, fetus. And by doing ultrasound also, we can able to know that by putting a Doppler, we can able to know the presence of a cord just below the presenting part and above the membrane. And this will help in diagnosing the cord prolapse or cord presentation.
Cord presentation, right?
Cord presentation, yes, ma'am.
So for this cord presentation, definitely you have to go for elective cesarean section. You don't wait for this patient going to labor, right? So there's absolutely no question of induction or going for ARM. There should be no intervention at all. And this, if at all you have cord presentation, you have to take this patient for elective cesarean section. But suppose she doesn't have cord presentation, she just have either transverse lie or breech presentation. Then what is your plan of management?
Madam, if it is a if it is a extended breech and the pelvis seems to be adequate, and in multigravida
presentation little later, we do have the case for that also. But if at all you have malpresentation or abnormal lie, definitely at around 30
cesarean section has to be
decide your modality that as cesarean section and go for elective cesarean sections, right?
Yes, ma'am.
So
yes,
I think that should be all for this case. Early identification of the patient at risk and early detection of cord presentation, posting her for elective cesarean section. If at all she goes into labor, you have to make sure that you don't do ARM, which is so catastrophic and disaster. So I would request the expert, Madam Jayashree Patnaik and Dr. Sasmita. So can we have some inputs from you, Madam? Do we have both the experts here?
Ma'am, this case actually is a eye opener for all of us because such scenarios can happen in our day-to-day practices, and we should go by the recommendations which are now recently changed very much. We need not go for repositioning of the cord and do things like that. But we can also we can prevent this cord prolapse by screening the patients beforehand and before going to before labor. And if a CTG machine is there, whenever there is a cord compression, we can know it by our CTG machine, and there will be variable deceleration which can predict that somehow somewhere it is compressing the cord.
Perfect. Perfect. So whenever you have FHR variability, you confirm it that there is, even though you don't feel the cord, there is variable deceleration, and that's a patient you need to take for emergency cesarean section. So thank you so much, madam, for your inputs. We go ahead quickly to the second case, and Dr. Abhishek. Do we have Dr. Abhishek here?
Good evening, ma'am. I'm here, ma'am.
Yeah, good evening. This is a patient for you, 28-year-old, fourth gravida. She has had 3 spontaneous abortion. Now she is 39 weeks in labor. She delivers a full-term baby girl, but the placenta fails to get expelled even after 45 minutes of birth. So what is your diagnosis and how would you go ahead with the management of this case?
Ma'am, the placenta has not expelled even after 45 minutes of birth. So going by the definition by the WHO, that after delivery, if by 30 minutes the placenta is not expelled, then the diagnosis is of retained placenta, ma'am.
Yeah, retained placenta. Perfect. So how do you go ahead with the management? What do you do routinely?
Ma'am, going by my own experience as well as the common causes, the number one thing which comes into play is how the labor has gone, whether it was a prolonged labor, whether too much of oxytocin was used during augmentation. So my number one cause will go towards atonic uterus, and followed by prolonged labor, as well as there may be uterine anomalies like some septate uterus. And going by the increased amount of cesarean these days and the number of curettage which is being done, morbidly adherent placenta will be one of the major causes. And how I will manage? Yes, ma'am. My management process. Yes, ma'am. My management process will include. Personally, I prefer to do any kind of manual removal in the OT, ma'am. This is what I prefer. So I will arrange adequate amount of blood.
Dr. Abhishek, just a minute. I would like to interrupt you here. See, this patient, it's only retained placenta. There's no mention about the bleeding or postpartum hemorrhage, right? So would you like to go for ultrasound first? Would you like to go for ultrasound even at this point of time to rule out placenta accreta?
That won't be my first step, ma'am. That won't be my first step because she's G4E3 in this case. And here this is yes, ma'am, 3 spontaneous abortions. But I don't have any other history of any surgery which has been performed or vigorous curettage history is not there. But I expect since it is A3 might be there. So I will try to explore it. And if I'm not able to separate it, then I will probably think of doing an ultrasound.
But then I think that can lead to disasters if at all you try to.
Yes, that is true.
So best way is even if there is absolutely no abortion or even curettage, this case, so definitely there are three
abortions are there.
Maybe. So this is actually a high risk patient for PAS or placenta accreta. But even if it was not there otherwise also, when she is not bleeding, Okay. In fact, that is an indication that at least at this point of time, you rule out at least. Okay.
Yes,
And
ma'am.
then, of
Yes.
course, because usually you have the obstetric ultrasound nowadays at your disposal, even in the labor room, maybe in your
Yes, ma'am, we
hospital.
have.
And then you try to rule out. Once you're sure that it is not morbidly adherent, you're free that, you can do all sorts of manipulations in OT, of course, preferably, as you said. And now what will you do? Suppose you find that ultrasound says, no, absolutely fine, it is not morbidly adherent. Then what is your next step? And by the time, what?
Ma'am, first of all, I will prepare myself like double IV line and blood products. I will give a requisition for the blood because it is well known that after postpartum hemorrhage, retained placenta is the second most common of hemorrhage after PPH. So I
Okay.
will keep a blood in hand and I will prefer to go for regional anesthesia and sometimes even general anesthesia just to deepen the plane of anesthesia because it will help me insert my hand more easily and to get the plane. So
Yeah.
meanwhile, I will start
Yeah,
oxytocin
as
IV,
you
ma'am.
said
Yes, ma'am.
very rightly that, sometimes you have prolonged labor or, maybe the uterus becomes atonic. So full bladder, distended bladder
Yes,
is
ma'am.
also one
Distended
of
blood.
the causes. So first and foremost is,
Yes, we empty the
catheterizing the
bladder.
bladder,
Yes.
emptying the
True, ma'am.
bladder
True.
and then starting
After,
oxytocin.
before any maneuver, ma'am.
Okay, now you go ahead with the manual removal.
The manual remover placenta, I will put IV syntocinon or oxytocin and I will continue the drip and I will I will take all aseptic measures and keeping the cord in one hand, straightened up and mild bit of traction. I will insert conically my hand inside the in the vagina and try to get it inside the uterus and try to find the plane between the placenta and the uterus. And I will try to indent that space. And when I insert my hand and when I have finally taken the plane, then I will use the other hand with which I was holding the cord to push the uterus in the opposite direction like we do in Brand Andrew method.
Correct.
And I will try to indent my hand with all the fingers joined together. I will try to go in between the space
Create
and
a
I will try to separate it.
And
I'll
then
try
once
to
you separate all around, you just turn the placenta like as if you are, turning the page of a book. And
Yes,
with
ma'am.
the same hand, you come out with the
Yes,
placenta.
ma'am.
Okay, now what do you do? You have removed the placenta. Now what do you do?
Now, first of all, when I remove the placenta, I will check on the maternal surface of the
Yeah,
placenta whether
oxytocin. Any other oxytocin you want to add, if at all, here?
ma'am, at this moment of time, now that the placenta has come out, ma'am, and there is a very, very good amount of chance that again it will bleed. So I can use methergin, I can use carboprost, I can use per rectal misoprostol, 800 to 1000 micrograms.
Perfect.
Yes, ma'am.
Yeah. So now what will you inspect? This is we are discussing for the attendees. So I'm very
Yes,
happy that you are going very systematically. Please go ahead.
Ma'am, then I will check. Uh, Meanwhile, while I have given the oxytocin, I will check the submaternal surface of the placenta because in such cases, placenta coming out piecemeal is not very surprising. Many a times it is left behind. Our own intervention causes infection and leaving behind a certain amount of tissue will cause further PPH along with the atonicity, which was already there. And if adherent placenta is there, certain amount of tissue will be left behind. So I will check if it is there, and if some piece is missing, while I am giving the oxytocin, I will try to curate it out, probably with sharp dissection.
Right. Any importance of inspecting the fetal aspect? Sometimes you have that, if you have left out the cotyledon, you can see it on the maternal aspect, right? But
True,
sometimes you have the succinsurate lobe.
Succinsurate.
So
Yes,
if you have, yes, in continuation, you can continue inside. So that is how the importance of inspecting even the fetal aspect. So you have to, given the oxytocin also, and then of course you monitor and manage as per the routine management of the third stage, correct? And even the immediate postpartum. So that is nice discussion, Dr. Abhishek. Thank you so much. We go ahead with the third case now, Dr. Sagarika. Anything to be added, Madam Expert? Jayashree Madam or Madam Susmita, anything from your side?
No, ma'am. No, ma'am. To please go ahead.
Thank you so much. So we go ahead with Dr. Sagarika now. I can see you, Dr. Sagarika. Hello. So this is a second Dravida, para 1, with 36 weeks pregnancy, and she comes to you with previous normal delivery, and now she has strong labor pains. Okay, her vitals are normal. Fetal heart is also good. She's fully dilated, fully effaced, and you find that the breech is popping out from there. Station is +1, pelvis is adequate. How would you manage this patient, Dr. Sagarika?
Yeah, good evening, madam, and good evening, everyone. We are in this case scenario, we can go with two options. One is an emergency cesarean section, and other is an attempt of vaginal breech delivery.
Correct.
Yes, as the patient is a second gravida with previous vaginal delivery, she is near term 36 weeks with an average size baby, and pelvis is adequate. So there is no absolute contraindication indication for emergency cesarean section. There is no absolute indication. So we can attempt a vaginal breech delivery. For that, we have to take informed consent of the patient. If we have a facility where there is a facility for
Hello.
Emergency C-section, we all know that C-section reduces the intermittent Berkshire. The breech delivery uh, is not
Hello.
completely followed up, or if there is adjustment from here on, then go for
Hello.
Hello, it seems signals are weak, madam, for them.
Yeah. Yes.
Hello?
Yes. That is what I thought. That's the reason I'm changing the my Wi-Fi. I'm changing the Wi-Fi, if at all, because it's raining outside. So I'm just changing the Wi-Fi.
Dr. Sagarika, your net is okay, no?
Yes. Yes, ma'am.
Because the answer you gave, last part, actually we missed to hear. It was like little disturbance in the answering. It was, otherwise you are answering well.
Is it disturbance from my side or is it from Dr. Sagarika?
Ma'am,
Can you hear me? Can you hear me?
Okay, ma'am. There is no interruption from your side, ma'am. We can listen to you.
Okay, then it's okay.
Yeah.
So go ahead. I thought, so I have changed my Wi-Fi now. No worries. So Dr. Sagarika.
Yes, ma'am.
Now you said that you have to decide whether to go for emergency cesarean section or we have to go for assisted breech vaginal delivery, right? So by the time you are discussing this with the patient and the relatives, maybe sometimes it can happen that the patient pushes and the baby is pushed out and that's a spontaneous breech vaginal delivery, right? That also can happen by the time, because she has had one previous vaginal delivery and now this is the second time. But suppose she's pushing the breech and only the breech has come out and now you have to go for the assisted breech vaginal delivery. So how do you go ahead with that?
In case of an assisted breech delivery, the delivery is conducted at 3 steps. One is the delivery of the buttocks, then the shoulder, and then the aftercoming head.
Right.
In assisted breech delivery, for the delivery of the buttocks, and if it is frank breech, then the extended legs are delivered by Pinard's maneuver.
Yeah.
And then the extended arms are
What is the Pinard's maneuver? Suppose
that is, we have to Yes, ma'am. That is, we have to catch hold the legs and give pressure on the popliteal fossa so that we can flex the knees and deliver both the legs.
You tap in the popliteal fossa so that the legs is flex, and then you catch hold of the ankle and you deliver the lower limb. Right.
Yes.
Okay. Now, suppose your half the baby has come out. You can see the scapulae. Now you have to deliver the upper arm. Right.
Yes,
How
ma'am.
do you do that? Suppose it's a knuckle hand. It's going up like that. Then how do you do that?
In case of extended arms, like you told, we will do the Lofsted's maneuver. It is the exact procedure. Then we'll just catch hold of the arms and we'll flex the elbow joint and we'll deliver the anterior shoulder first, followed by the posterior shoulder, swiping over the perineum.
Yeah, Lossett's is you just rotate the body, right? Rotate the body and again rotate the body 180, so half circle. But then if you have a knuckle hand going up, then you have to go over the shoulder, follow the humerus, go into the elbow, and then you deliver. Correct? That is how it is. Okay. So now your most of the trunk has been delivered. Now, how do you deliver the aftercoming head?
There are 3 methods to deliver the aftercoming head. One is we can use burn muscle technique, one is modified Mauritius Mellivith, and one is we can use Piper's forceps. The forceps is usually recommended because it gives direct pull on the head. There is no transmission of pressure on the neck.
Okay.
So we can use Piper's forceps for that. In burn muscles
But
technique,
here, see, most of the practitioners may not have the Piper's forceps, and
yes, ma'am.
they may not be, well versed with the technique, because these are the, they have long pelvic curve. So the obstetrician has to actually kneel down, sit down. And the application also is little different from the routine application. So forceps, I think those who are well versed, well and good. But if you are not well versed, you don't have the forceps, you have to go ahead with the manuals.
We have to do with the maneuvers. In the burn muscle technique, the baby is hung first on its own weight. Then the suprapelvic pressure is continued to give flexion. When the nape of the neck is visible beneath the pubic arch, then both the ankles are grasped and a wide arc of a circle is performed, giving traction so that the mouth is delivered and then the trunk is depressed to deliver the baby.
Okay.
In case of burn muscle technique, and in modified Mauritius Mellivith, the baby is held over our supinated left arm. It is a technique of malar flexion and shoulder traction.
Right.
So with the supinated left hand, the index and the middle finger are placed on the malar bones to give malar flexion. Then the pronated right hand, with the pronated right hand will provide the shoulder traction. The index finger is placed over the left shoulder, the middle in the middle finger on the nape of the neck, and then the ring finger and the little finger over the right shoulder.
Middle finger
On the
is at
occiput,
the
on the occiput.
to aid the flexion of the head, right?
Yes, ma'am. And then the ring finger and the little finger on the right shoulder, then will provide continuous traction, shoulder traction, continued with malar flexion and shoulder traction, and then will deliver the baby by giving forward and upward traction.
Right. So that is all. I think only thing is what you have to follow. You have discussed it well. Only what precautions you have to take is no unnecessary traction, no unnecessary push from above.
No pull and no traction.
Yes, no push and no pull. And of course, you have to maintain the back anteriorly. That is the most important. These are the tips, these are the recommendations. So well done, Dr. Sagarika. You have delivered the bridge very well with assisted bridge vaginal delivery. Now we move on to the next case. Dr. Vandana Mahapatra. Dr. Vandana?
Yes, good evening, ma'am.
Good evening. Good evening. So we have this, 34-year-old second gravida. She's got gestational diabetes, and she comes to you in labor at 37 weeks. Okay. When you examine, you find that yes, appropriate growth 36 weeks, and head is 3/5 palpable. Fetal heart is good. Cervix is only 2 centimeter, but fully effaced. So she progresses very well, and within next 6 hours, she becomes fully dilated, fully effaced. After 20 minutes of full dilatation, the head is delivered. But the shoulders are stuck, and she's trying to push and push, but it is not coming. It's stuck like this. What is your diagnosis?
Yeah, this is, ma'am, diagnosis of shoulder dystocia. Here,
Okay.
the restitution is not there. The fetal head is tightly opposed to
Yeah.
the vulva of the woman, and the face also appears edematous and puffy.
Edematous,
So this is a
right.
case of shoulder dystocia.
Perfect. How will you manage?
Okay, so the first thing is diagnose a case.
Yes.
Shoulder dystocia and preparedness. So diagnosis, as I told, there will be failure of
Is there a
body with
disturbance in Dr. Vandana's side?
and then there will be restitution of the head and by gentle practical surgery.
Yeah, you can close your video.
Ma'am, now is it clear?
Yeah, perfect.
Yes. So, what happened? Okay, ma'am. Yes. So now we have to keep the do's and don'ts in mind, and then call for help. That is most important. A help mnemonic, we follow that. So
Yeah.
call for help. Any assistant whoever is available in the labor room, and also arrange for neonatologist and inform the anesthesia team if need arises. Then the E stands for a liberal episiotomy. So this episiotomy actually would help in any internal maneuvers if we proceed to, and then this elevation of legs. So that is a macrobox maneuver. Yeah, elevation of legs. So we hyperflex the legs and abduct the legs so that the thighs of the woman touch her abdomen, and this helps in increasing the anteroposterior diameter. So, along with this, we have to also provide suprapubic pressure in the right direction. Right direction means we have to put on the side of the fetal back towards downward and lateral direction so that the anterior shoulder is moved to the wider oblique diameter of the pelvis.
Right.
Then if this also fails, then next resort is the second line maneuvers, that is the internal rotational maneuvers, that is the Woods corkscrew maneuver, and we can also resort to delivery of the posterior arm. So all these are the second line maneuvers. If this also fails, then we can have another maneuver, that is the all fours maneuver. There's a Gaskin maneuver.
Yeah.
That is possible only if the woman is slim and mobile. So all fours maneuver is possible. Then we also can repeat all these maneuvers, and our aim is to deliver the fetus body within 5 minutes of delivery of the head so as to reduce the chances of any hypoxic injury. So that is very, very important.
Correct.
And lastly, the last resort is if everything fails, then we have to go for Javanelli procedure, which we usually never perform. Javanelli symphysiotomy can be done in low resource settings, and cladotomy if the IUD is there. So this is the
yes, perfect.
algorithmic approach.
So how does this, this is actually, hyperflexion of the, thighs on the abdomen and the lower limb, the knee. Oh, correct. So it straightens the passage. It straightens the passage and widens or increases the anteroposterior diameter. Right. And from where do the assistant gives the suprapubic pressure? Which side?
From the direction of the fetal back, actually, on the anterior shoulder, the suprapubic pressure is given.
Yeah.
So that is very, very important.
From outside, what is visible is occiput. So you have to see which side the occiput is facing, and that side the pressure should be given.
From that side, we have to give the pressure.
So that,
and that will help in moving the anterior shoulder to the wider oblique diameter. And this macro, but as you told, ma'am, that will increase the relative anteroposterior diameter of the pelvis.
Right. And this is what you described, the Woods corkscrew. Here, actually, you insert your finger and turn it, through 180 degree, that is through half circle. The anterior becomes, because already your posterior shoulder has escaped and it is at a little lower level. What is, stuck there is the anterior shoulder. So when you rotate the baby through half circle, the anterior becomes the posterior. So that also now comes to a lower level and gets delivered. Yeah. And then, of course, you have various other maneuvers, which actually, if everything fails, the Javanelli symphysiotomy. Okay, so that was
most importantly is we have to keep in mind the don'ts also, like we should never give the fundal pressure. Suprapubic pressure is must, but never fundal pressure, and never tell the woman to push. So that is very important.
And of course, pull also. No traction. Correct. Okay. So
Yes.
that should be fine. And here you have one more, I think one more case, that is second gravity previous seizure. This is a simple case again, just to recognize contractions every 2 to 3 minutes, and then that is lasting for 30 to 40 seconds. So good contraction. Cervix is 6 centimeter dilated, fully effaced, station at 0, and now she is fully dilated, but there is sudden severe bradycardia and fresh, she's got hematuria. So what is your diagnosis, Dr. Prasanna, and how would you go ahead with the management?
Yes, madam. As you said, the case is simple, but if you manage with the obstetric emergency, if you see when you are allowing a case of a previous cesarean scar for a normal vaginal delivery and cervix is 6 centimeters, always we should have in our mind the sudden uterine rupture, and hence it is one of the complete obstetric alarm thing. We have to save the baby as well as mother early as possible, madam. It's a case of uterine rupture.
Right.
So when
and
you
have to go ahead with.
Yes, madam. So, like this case, when she is second gravida with previous cesarean section with a scar, always before there's one entity to measure that this woman can be proceeded for a normal vaginal delivery by doing ultrasound beyond 36 weeks to know the anterior uterine wall thickness. So,
Right.
we can confirm the regularity of the scar and thickness. If it is at least more than 6 mm, these things can be allowed for a normal vaginal delivery. Between
Yes. Whether she is eligible for VBAC, that is what. Yes.
Yes, ma'am. If the anterior uterine wall thickness is 6 mm and above, and with a regular wall contour, then these cases can be allowed for a normal vaginal delivery, along with well settled head presenting part, and it is a good pelvis, average size of the baby. There are many other factors we take into consideration to allow this woman for a normal vaginal delivery.
Yes. So that's a very, very important message, that it is never that you allow her normal vaginal delivery, but it's always a trial of labor. Once she delivers, yes, we can label her as VBAC, yes, vaginal birth after cesarean section. So friends, intelligent anticipation, skilled supervision, prompt detection, and effective institution of the therapy can prevent disastrous consequences. Of course, not to forget communication, that should be transparency and time to time appropriate communication, and of course, documentation of the communication. So friends, thank you so much once again for all your wonderful inputs, and I would request the experts also to make few comments. Before that, I just take this opportunity to humbly request all of you to please nominate me from your society, and all of you please vote for me. I am a hard-working, hardcore obstetrician, and of course, I am the representative for all of you. So that's a humble appeal from my side. Thank you so much, and maybe have some comments from the experts.
Thank you, Sneha. It is a very useful and practical discussion, and every panelist has discussed and very practical things, and it is very useful to every obstetrician. And thank you, Sneha, and thank you, Bhagya, for this important topic keeping in today's discussion. And thank you all. And I wish Bhagya and Sneha will be our next vice president for coming year 2025 and 26. Wishing you all the best. And one thing I have to add some small thing. In manual removal of placenta in a previous cesarean or in normal delivery in a previous cesarean, we have to see the scar integrity. And after any vaginal delivery, whether it is instrumental or normal, we have to inspect cervix and vagina thoroughly, so that we cannot have a further problem within few hours. Thank you. Thank you.
Yes. Thank you, madam. The message very well delivered. Exploration of the cervix as well as vagina is a must following any manipulative or instrumental delivery. Thank you, madam. Thank you so much for your valuable inputs. Do we have any other comments here so that otherwise we can end? I think I can see Dr. Gangadhar Sahu sir also. Sir, any comment from your side? Sir, thank you.
So I am listening from A to Z, starting from the until the last. So it is totally observing. Just I am going to sum up within 2 minutes, if you allow me. So that is WHO labor guide. The talk was fantastic. So Dr. Pai, he has his verdict, what I analyze. That is, I think I am totally absorbed with your talk, with his talk. Second talk was on postpartum hemorrhage in low resource conditions. And speaker was none other than the Dr. Sheila Mane, who is famous as the PPH lady or PPH queen, whatever you may call it. So out of these talks, what is my take-home message? In the first talk, the WHO labor guide has given us some relaxation, some freedom, both to the patient, to the doctor, obstetrician, and to the family members. So well bit relaxed, so not so much tense. In postpartum hemorrhage, what I always teach to my students and what I learned also from Dr. Sheila is that one should not be complacent, number one, while dealing with any labor. A mother, whether with risk factor or without risk factor, who is entering into the labor room, we can take that she is likely to have postpartum hemorrhage unless otherwise proved.
Yes.
So nobody is immune to it. So therefore, there's complacency should not prevail in labor room.
Yes.
Nor also experimentation. New drug, this thing, that thing. If you have not expertise on that, please, for heaven's sake, don't use it. If you are not expert in doing internal iliac ligation, don't venture it. Better if you are expert in doing an hysterectomy, save the life. Forget about the uterus. So therefore, don't adopt something or any experiment should be avoided. Therefore, the dictum is heroism should be avoided, heroics in the labor. And from your discussion, and it is a marvelous one, so many cases are being discussed. So out of all, what is the take-home message I want to give to all the audience who are taking part is that we are scarcity of one thing now in modern obstetric practice. Guess who or what? That is a dedicated obstetrician. So in anywhere you go, who will administer all these things, whether it is a maneuver, whether it is a drugs, whether it is surgery, who will take this, whose opinion counts. So those time-tested, gray-haired obstetricians are now almost an endangered species. So hopefully the younger generation will take up this challenge and come up with all their patience, all their knowledge to be in the labor room to save a life. Thank you, Sneha, for inviting me. Once again, I pray Lord Jagannath to bless you. So that's all. Thanks all the guests, experts, panelists, speakers. So actually making me to stay till the end. Thank you very much.
Thank you, sir. Thank you so much for everything, sir. So I would just like to formally thank respected Dr. P.C. Mahapatra, sir, Dr. P.K. Shah, sir, and of course our guest of honor, Dr. Sujata Mishra, madam, who could not join, but Dr. Kiran Kurtakoti, Dr. Gangadhar Sahu, sir, and of course Dr. Tusharkar. It's my privilege to thank Dr. Murlidhar Pai, sir, and Dr. Sheila Mane, madam. It's wonderful, and Bhagya is a wonderful friend, and she is the one who has helped me to organize this program. So thanks to Bhagya, and of course Dr. Madhusmita and Dr. Preeti, Thank you all the chairpersons and experts and panelists. Thank you so much once again. Thank you.
Madam, thank you so much.
Actually, dedication of Bhagya and Preeti, that is awesome. So I wish Bhagya also all the
Yeah,
best.
Bhagya, we have to congratulate sir. Bhagya is going uncontested and she is already our.
Oh, acha.
So,
Acha, acha, acha.
so you
Okay.
have to bless
So
me.
Bhagya, congratulations. Congratulations. Thank
So,
you.
thank you so much, sir. Thank you so much, everybody. And
Madam, best of luck.
thank you. Thank
Wish
you.
you all the thank you very much for giving me the opportunity, ma'am.
Yes.
Thank you.
Thank you, my dear. It's my pleasure. And I request once again all of you. It's yeah, I would need your help. Thank you so much. Thank you. Good night.
Namaskar, sir. Gangadhar sir.
Namaskar, namaskar. Prasanna. So you are always Prasanna. Good. Nice to see you.
Yes.
Okay. Thank you. Okay. Keep it up. Keep it up.
Namaskar, sir.